Hello, everyone. My name is Mary Corey. Welcome to the pre-work webinar for part 2. I will be moderating today's event. I'd like to mention a few quick items before we begin. First of all, please make note of the features available to you within your GoToWebinar internet browser. In the lower right corner of your screen, you could see the chat box where you can find your questions, where you can submit your questions to Dr. Rosier. They will be answered at the end of the presentation as time allows. This should be after part 2. Dr. Rosier's presentation will be about 2 hours in length and will be sending all attendees the recorded version. It is my privilege to welcome Dr. Neil Rosier for today's webinar from his hometown in Palm Springs, California. Hello, Neil.
Hi, Mary. Good morning, and hello, everyone. No, I'm not in Palm Springs today. A little different change in venue. It's always 35 bright, sunshiny skies and beautiful in Palm Springs. I'm actually up at the ski resort where I work. Carolyn is out skiing while I'm doing the webinar. We have presently over 650 inches of snow so far this year, which has surpassed our all-time record. Most of the homes are being excavated by excavators because the snow is up and over the top of the roofs. It's just absolutely, thoroughly phenomenal, the amount of snow up here, and everyone's still trying to dig out. So the good news is the drought is over. Anyway, good morning, everyone. This is section 1 of part 2. The intent of this first lecture is to explain why we do what we do. Part 1 was a lot of journal articles, medical review, why we do what we do, the medical support for it. This is more of a general lecture that I have given to medical academies in the past to try to explain why we do what we do. And there's a couple different aspects of it that I want to go through with my usual sarcasm that I try not to use in the lectures themselves, but I can with this to try to explain to all of you that it just makes no sense why, let me use the term, mainstream medicine continues to promote what they do and ignore the medical literature and the studies to tell us what we really should be doing. There's a multitude of benefits as far as health are concerned. There's a multitude of benefits as far as feel-good effects are concerned, and I want to share those with everyone because I didn't get a chance to do that in part 1, but I want to do a nice general lecture on what we should be doing for our general health, and all physicians should be doing this. So that is the intent of this first section, to try to explain why we do what we do. This course used to be called an anti-aging course. I also lecture for the National Procedures Institute, which is owned by the Texas Academy of Family Practice. And for years we had this course named anti-aging. And when the AAFP bought it and took it over, they notified me that they would no longer be needing my services because the course did not meet their standards. And when I asked them what exactly that meant, they said, well, they don't really like anti-aging, the term of it. And I said, well, then why don't you change the term to something else? Why don't you call it preventive medicine instead? Because that's basically what it is. And they said, well, we still don't like the course itself. And I said, well, before you nix the course, the hierarchy needs to attend the course, and then you can decide if you really want to get rid of the course. And of course, there were 5 people from AAFP that attended the course and said, you know, yeah, this is the best course I've ever attended. Boy, it's preventive medicine at its finest. No, we won't nix the course. We'll keep the course. And it is always their best attended course. The other courses, they may get 10 or 15 people. They always end up with 30 or 40, and they always end up going over. So it is their most popular, favorite course and also the most profitable for them. So they decided not to nix it, but they said, we have to change the name. We got to get rid of anti-aging. We don't like that term. Nobody likes that term. I don't like that term because nobody else likes it. So they said, well, what do you think? And I said, well, let's call it preventive medicine. So we put out, we changed the name of the course, same course, and we used the term preventive medicine. Well, the next year, as it remained preventive medicine, they had like 5 people sign up for each course. So anyway, that was a big flop. And so I said, why don't you change it back to anti-aging and just deal with it? They changed it back to anti-aging. The next year, every course filled up with 50 people, and they were happy, and it's been the anti-aging course ever since then. But nevertheless, I will show you how the AMA denigrates anti-aging. I will explain how there's adverse opinions and negativity to the term anti-aging. So I also strongly suggest that you do not use the term anti-aging in any of your material. I suggest that you remove it from any material that you use, your web sites that you use. I suggest that you remove it and not use it. So what term do we use in place of it? I don't know. I'm not quite sure. The term is complicated, it's complex, it's really ill-defined, it's confusing, misunderstood, denigrated by mainstream medicine, but still, I don't think that we should throw the baby out with the bathwater. So, how do you define anti-aging? Let's define aging. What happens when you get old? Well, you lose protein synthesis, you lose your immune function, you lose muscle, you lose strength, endurance, you get fat, you lose bone. There's an increase in all the age-related diseases that kill us. So it's extremely important to replace hormones to prevent all of these things from occurring. Well, that's great, but what term should we use? What term can we call it? Back in 1990, there was an article that was written in the New England Journal of Medicine by a doctor who termed the effects of growth hormone that were seen reverse the changes in aging that were seen over the prior 10 years. And at that point in time, the term anti-aging was coined. And it's been called anti-aging ever since because of the improvements that we see. But if we don't use that term anti-aging, then what term can we use? I'm not really quite sure. So let's look at the possibilities. When you get old, you lose hormones. Hormones will help prevent weakness, impaired mobility, loss of strength and endurance, loss of energy, loss of desire to do things, our work competence. We get pain, we get muscle aches, we get joint aches, and when we're in pain, we have less activity, and as a result, we move less, and when we move less, then we deteriorate. So the whole key is to try to prevent all this from occurring in the first place. Don't wait until that occurs and say, okay, now let's try to reverse it. What we should do is to implement a therapy to try to prevent that from occurring in the first place. That sort of makes sense. So as you get older, you fall down, you lose your balance, and then you fracture, and then you have impairment of activity, loss of independence, poor quality of life. And patients want a better quality of life. They don't really want to go to the doctor and be put on a bunch of medications that they don't want to take, that have side effects problems, and they want to try to avoid those medications. So how can we avoid the medicines? How can we avoid the problems and complications that we see as we get older? This is exactly what anti-aging or preventive medicine is all about. Unfortunately, it's not well embraced by mainstream medicine. There's lack of pharmaceutical support for it. And of course, the adage for many doctors is, well, you know, I know you feel lousy, I know you look lousy, I know you're deteriorating, but, you know, here, take this cholesterol medicine, take the diabetes medicine, take the blood pressure medicine, but that makes me feel worse. Well, Fred, you're just getting old. Martha, just deal with it. You're just getting old. And unfortunately, patients know and understand what hormones are all about, but doctors are not. They're not well informed, and they're against it, which is really a shame. So the therapy is patient-driven. It's not doctor-driven. There's a few doctors in my area that will refer patients to me. But most of the time, most doctors are against it. They don't understand it. There's no AMA support for it. But yet, as we saw in part one, it's all evidence-based medicine. It's just simply ignored by mainstream medicine. And it shouldn't be. We should not ignore these studies. We should not ignore the literature. Why do they do the study? So that we can learn from it. Why do they publish it? So that we can learn and understand maybe what we should be doing. Then why do we ignore it? It makes no sense whatsoever. So patients are requesting anything to help maintain quality of life. They want to feel better. They want to function better. They don't want to take drugs and medications, and they want to maintain that activity. It's called preventive medicine. We used to call it anti-aging medicine. I suggest that you don't call it that anymore. It's feel-good medicine. It's basically average, everyday medicine that every doctor should know and understand and practice and preach and it should be embraced by mainstream medicine, and it should be embraced by all patients. It's just one of those things, again, that falls between the cracks, which is very unfortunate. Until we can get into the DNA, hormones are our best method so far of reducing the morbidity and mortality that we see from the diseases of aging, and how to preserve our independence, our strength, our quality of life, how to reduce those symptoms, how to not deteriorate and get the aches and pains, and then try to take the pain medicine to get rid of those pains. Preservation of health and wellness is really what we should focus on, and I showed you multiple articles in part 1, and we'll go through that also in part 2 to look at what the medical literature support for what we do and why we do is so beneficial, and it's so much evidence-based, and it is a shame that mainstream medicine just doesn't get it. The flip side to that is I always look at the silver lining. Maybe it's good that mainstream medicine doesn't get it. Well, it's not good for the patients, but maybe it's good for us, because the more that my family doctors don't understand, the more the patients will come to me, and I can make them feel better, and I can make them love life. I can make them get off of the medications that they don't want to take. The second section of this morning's lecture will be looking at lifespan, but more importantly, we really want to increase and extend health span. When you increase health span, you will extend lifespan. No one wants to live forever. No one wants to be in that nursing home in that fetal position, not able to move or function. We don't want the debility. We don't want the chronic illness. We don't want the cognitive impairment. For 40 years, the pharmaceutical industry has spent billions of dollars trying to prevent and reverse Alzheimer's disease. We are no further along the road as far as treatments or prevention than we were 40 years ago. And we've spent billions in all of these new drugs to try to reverse and remove beta amyloid protein from the neurons have failed miserably, unfortunately. But yet, for those of you that attended part 5 last year and saw the benefits that I gave in the brain lecture of all the hormones, it's just mind-boggling, pun intended, what hormones do for the brain and to protect against Alzheimer's disease and to actually even reverse it. We'll get into that later in part 4 when I will repeat those lectures on the brain and all the benefits of hormones. And it's just phenomenal, the data and the studies that are there from the neurology literature and from the Journal of Alzheimer's Disease, what's there. And we ignore it, and we completely do not understand because we do not understand the literature. I am trying to make everyone be analytical thinkers as opposed to reactionaries. The reactionaries will say, well, the studies show that hormones are bad, estrogen's bad, you shouldn't take it for a short period of time and stop it. That's the reactionary. The analytical thinker will say, well, yeah, that's true, that's what Pertinent showed, but that's not what we see with estradiol. In fact, every study with estradiol shows protection of our brain. It reverses beta amyloid protein. It protects against the deposition of beta amyloid protein, and it actually reverses it. And we see that in the SPECT scans. Then what is it that we don't understand? Well, you can't take estrogen because it's harmful. No, it's not harmful. You're extrapolating the harm of Pertinent to estradiol. Well, you have to assume that they're the same. No, they're not the same. And all the studies show that they're not the same. But the problem is that mainstream medicine does not understand or know or realize those studies. The reactionary, they're not analytical thinkers. I want you to become analytical thinkers to be able to understand what mainstream medicine is missing, why they miss it, why they extrapolate and assume and incorrectly make suppositions. I want you to be able to look through that and think through that and look at what the data and what the studies show. And then you'll be able to understand what we can do for the brain. How many hormones improve the brain? DHEA, thyroid, estradiol, testosterone, growth hormone. All of those have been shown to reverse beta amyloid protein deposition and improve cognition and memory. What is it that we don't understand about all this literature and all these studies? Well, you can't take them, they're bad. No, they're not bad. You're extrapolating that which is bad to that which has been good in every study. So who would not want to extend this vitality and compress morbidity into a very small, limited time? That's the key to what we do for anti-aging medicine. And get the concept in your head. It's preventive medicine. That's simply what it is. Vitality extension, morbidity compression through preventive medicine. What a concept. everyone should embrace it. It's a shame that they don't. If we increase our lifespan, then we want to be happy. We want to be healthy. We want to be vigorous, happy, content, healthy, motivated, free of disease and illness, which is the key. Sorry, the drugs that we often use do not reverse the disease and illness. You can reverse it, and you can improve it and prevent it by optimizing your hormones. So what drug does all of the above? Makes us feel better, function better, and makes us healthy. There is not one drug that does this, but it's interesting that all of us mainstream physicians push the drugs that don't. And all the ones that do, and I don't want to call them drugs, I want to call them hormones, are the ones that prevent. But we simply don't get it. We don't grasp it. We don't understand it. And it is my passion to try to explain this to doctors so that they do get it. Traditional medicine. We can treat the disease once you get it. Anti-aging medicine. Why do you need to get the disease in the first place? Focus on prevention. We can change the pathology from the get-go. Why wait until we get the illness when we can simply prevent it? And that's the whole key. And we'll look at this in section 2 on all the different hormones that prevent, that we fail to understand and acknowledge and embrace it. So let's forget the term anti-aging. And by the way, I want to thank Dana and Mary for putting together all the slides for this course. They're fantastic. And for Dana now creating this, instead of using the term anti-aging, let's use the term the science of creating health. That's what it is. Let's use that. Does that make sense? Yes. Does all the literature support that? Yes. Okay. So from now on, it'll be, well, what kind of practice? What people always ask me, well, what do you lecture on? And I go, I lecture on the science of creating health. And I go, what the hell is that? It's preventive medicine. Oh, I think I understand that. I don't use the term anti-aging anymore because people don't quite grasp that, or they'll denigrate it. So the science of creating health is application of any therapy or modality, vitamins, supplements, lifestyle change, hormones, to deliver and diagnose the early detection, prevention, treatment, or reversal of age-related dysfunction and disease. What a concept. What a great paragraph that all physicians should embrace and should understand why we do what we do. By doing so, we enhance the quality of our life. It extends the quality of our life as well as our lifespan and our health span. So that is the goal of anti-aging medicine, preventive medicine, age management medicine, whatever term you want to use. It's the science of creating health. And it should be a new specialty. It enhances the quality of life. That's what patients want. For those of you who have been doing this for a while and understand it, we can make patients feel better. Oh, I wish I had $1 for every time a patient has come to me and said, you've given me my life back. The spouses have come to me and said, you've saved my marriage. You've saved me. You saved me from my job. I was circling the drain. And now that I'm on hormones, I can't believe how much better I feel and how I function. I got my life back. I feel so much better. And you'd be surprised the number of patients that feel that, experience that, and come back and compliment me on it and will say, my doctor is clueless. My doctor doesn't understand. My doctor thinks that I need to get off all these hormones. My doctor thinks that I don't need to be on thyroid, but I feel so much better. I know. Don't expect your doctor to know and understand what we do. Just because you know and understand it does not make your doctor know and understand it. The science of creating health uses cutting-edge technologies to detect, prevent, and treat age-related disease. So it's scientifically based. It's evidence-based medicine. Everything I do and I teach and I preach comes from some medical journal article, and I usually back that up with many articles on the same topic. It's well documented and demonstrated in our peer-reviewed journals. It's preventive medicine. It's quality of life medicine. What a concept. But yet, it's not embraced, and I'll show you shortly how it is not embraced and why it's not embraced. So don't lose sight of what our science is trying to tell us. Why do they do the studies? So we learn. Why do they publish it? So that we can learn. And then why do we ignore it? That's the question. Well, because it's not in our thinking. It's not what we do. It should be, but it's not what we were taught or trained to do. People often ask me, well, when are we going to start teaching this in medical schools, in our residencies? I don't know. But nevertheless, I can at least show and train and teach doctors to use evidence-based medicine to support why we do and how we do what we do. Use the evidence-based medicine to guide us in our therapies, and that's why I give you all of these article studies and data to support why we do what we do. You can give it to patients, you can give it to your peers. You can tuck it away and understand what you have not understood for the last 10, 20, or 30 years, but that you now understand. So instead of simply trying to treat this disease and these problems, why don't we try to prevent it from the first place? And all the studies that I've given you show that we can prevent it. You can prevent coronary artery disease. You can prevent cancer by decreasing visceral fat. You can prevent dementia by all the hormones. And you can prevent insulin resistance and the deterioration, arthritis, joint deterioration, loss of muscle, ligaments, joints, tendons, bones, anything that holds us upright, our structure. We can prevent the deterioration in our immune system. And we can make what makes the world go round better. Sexual function, libido, energy. We can treat the cause, the aging. It's just basically getting older. The AMA, the FDA, and AACE have now come out trying to restrict the use of testosterone in men. We can't have everyone writing prescriptions for testosterone. Why? Well, because we just can't have it. Yes, but every study shows that there's benefit to it. Well, we can't have it. We shouldn't do it. It's only FDA approved for treating a disease of the gonads or the pituitary. If you don't have a disease of the gonads or pituitary, then you don't qualify for it. Yes, but it's the aging that's causing our levels to fall. Well, that's not approved for that. It doesn't mean you can't use it for that, but it's not FDA approved for that. And that's what the zealots are trying to now do, is to show us you should not use it because it's not FDA approved for it. Well, great. It doesn't mean you can't use it. You can use it off-label. 95% of the prescriptions for hormones are for off-label use. And it's basically preventive medicine. Don't get hung up on, well, there's no disease of the gonads, therefore it's not indicated. It is very much indicated for quality of life. This is a nice definition of what we used to use the term anti-aging, but the science of maintaining health is. There's a number of aspects of the aging process that invite the development of routine medical intervention programs. That's a hormone replacement program, offering long-term replacement, not short-term as per ACOG and NAMS. That's Prem-Pro. We don't use Prem-Pro. Long-term replacement with one or more hormones in order to delay the aging process and to allow us to live for a prolonged period of time in a relatively intact and healthy state. What a concept. That is the definition of quality of life medicine. That is the definition of maintaining health type medicine. That is why we do what we do. Quality of life. Preventive medicine, age management medicine. What other terms could we use? Feel-good medicine, preventing depression, reversing depression, making life fun again medicine. That's essentially what it is. And all the literature supports this. These are terms that I took from those articles. All hormones restored to 25 to 30-year-old levels and monitored by regular serum levels. I sort of disagree with that because in part one I showed you a dozen articles where your thyroid, testosterone, DHEA, sometimes estradiol, levels have to be supraphysiologic, above the range. But zealots will say, no, you can't go above that range. Well, that range is a range of average for old, sick people. Perfect. If you want to be in the range for old, sick people, well, then that's fine. Then absolutely you can do that. But I think that's more of a, shall we say, an advertisement to attract people. We're going to take your levels back to what you had when you were younger. Okay, that's great. No, I take my levels back to where symptoms improve. One of the physicians recently emailed me and said, we need to get away from these numbers. Get rid of these numbers because all the studies show that you're going to have to be super physiologic. Women have to be total testosterone of 200 to 400 in order to feel better. If you keep your level at normal of less than 70, you're not going to see or feel anything. You're not going to get that benefit. It has to be super physiologic, but the zealots will say, no, but it's something bad can happen. No, every study with super physiologic shows good. It doesn't show bad. So I use the number as a guide to my therapy. We'll look more in part 2 at numbers and the numbers that I use to achieve benefit. And the numbers will scare you because they're very high above normal. I don't shoot for normal. I shoot for optimal. With natural bioidentical hormones, whatever term you want to use, it's the same identical molecular structure. It is not something that is chemically altered. It's not something that's synthetic that has an adverse effect like medroxyprogesterone acetate and some of the other synthetic hormones that are used. It's quite simple in concept. The hormones that we have discussed in part 1 are listed. What are the effects on feel-good medicine? Sexual confidence, increased libido for men and women, increased sexual pleasure and performance for men and women. Note that the FDA has not approved testosterone for women. So, as a result, AACE in the last statement says, we cannot recommend it for women. Yeah, but what about the several hundred studies to show benefit? Well, we ignore it. And because we can't come up with a number and can't define a deficiency, therefore, and there's no FDA-approved testosterone for women, then we don't recommend it. Yes, but look at all the benefit that you're missing if you don't prescribe it. Improve sexual pleasure and performance, improve body image. It burns fat, it maintains muscle. Life is good again for men and women. Even into our 90s, I have told you the number of octogenarians and older that I have that love each other and still continue to have sex and have energy and go out and have fun and play. And that would certainly not be possible without being on hormones. I have some patients that have been on hormones for over 20 years. They started in their 70s. Now they're in their 90s. They still feel and function great. What a concept. Strength, confidence. It helps improve lean body mass, muscle mass, strength, endurance. You can do this with the anabolic hormones, growth hormone, testosterone, DHEA. There's a dramatic increase in strength and resistance exercise in every study that's looked at it. But yet, the AMA, the FDA, AACE says we don't recommend testosterone in older men. We don't want them to have increased strength and better quality of life. We don't want them to build muscle. We don't want them to burn fat. Why not? We don't want them to have improved healing. Why not? Because we just don't. That's so nonsensical, I just can't believe it. But you have to understand the politics and economics behind their wanting to restrict the use of it. But when you restrict, then people will lose all these benefits. They have got to be out of their mind. But if you understand politics and economics, you understand why they're doing what they're doing. That doesn't mean you can't prescribe it. It doesn't mean you can't utilize it. You're using it for off-label use to benefit your patients. And I document that. It's for off-label use. And you should document that in your notes when you prescribe hormones, particularly when you're using hormones when the levels are in the normal range. You're using it to help improve wellness, strength, energy, endurance, quality of life, and to decrease the diseases that we see with aging. It helps improve intelligence, memory, cognition, creativity. DHEA does this. Estrogen does this. Thyroid does it. High doses of T3. Testosterone does it. Every study shows the same. I hope you're all aware of the most recent study that came out. It was published. It was one of 7 different studies with androgel, and the one study showed that in men that took androgel, there was no improvement in memory or cognition. Well, I wouldn't expect there to be. They use androgel. It's a 1% gel. They got their levels from 200 up to 400. Wow. I can't figure out why they didn't see any improvement. It doesn't mean it didn't work. So what did that study show? The study showed that testosterone does not improve. No, that's not what it showed. It shows that in their study, in those patients that took a low dose of a 1% testosterone gel, they did not derive any benefit when their levels went from 300 to 400. That's the conclusion of the study. It does not mean that testosterone does not work. It does not mean that you throw out the other 200 studies that showed that testosterone does work to improve memory, cognition, creativity, and to prevent Alzheimer's disease. A poorly done study with a dose that does not achieve anything should not be used to trump all the other studies where they use good doses and good levels and they showed benefit. you can see how people will fall into this trap of reactionary. Oh, it shows that it doesn't work anymore. No. In that patient population using androgel in a very low dose, it did not work. Don't extrapolate that to what happens when you use a good dose, a 20% cream, to get your levels from 300 to 1800, not from 300 to 400. I wouldn't expect it to improve anything. That's a worthless study. It's flawed in its design because the doses that they used were not adequate. That doesn't mean it does not work. Salubrious, prevents the degenerative diseases of aging. All of the hormones, estrogen and all the anabolic hormones, testosterone, DHEA, growth hormone, have been shown to prevent the deterioration that we see in our muscle, ligaments, joints, tendons, bones, and skin. When we feel and function better, it improves our quality of life. It eliminates the depression that we get. There's a nice article that recently appeared in Scientific American that called antidepressants a drug with a strong placebo effect. Pretty interesting. In most circumstances, antidepressants don't work for most people because you're really not depressed. You feel lousy. And when you feel lousy, it makes you depressed. And when you're no longer feeling lousy, you're no longer depressed. That's the antidepressant effect of the hormones. I think everyone should be on hormones instead of antidepressants because in most circumstances, they don't work. It helps your immune system. It fights infections. It helps healing of injuries. A lot of the stem cell centers are now insisting that patients that do stem cells or PRP do it in conjunction with hormones. That's the key. That's the secret to prolonging your benefit. And of course, most importantly, a concept that most physicians do not understand, and of course the FDA, AACE, and zealots do not understand, numbers and levels are meaningless. It's a nice guide, but they're absolutely meaningless as far as predicting who is going to have symptoms, and they're meaningless as far as predicting who is going to improve. Almost everyone will improve if you use a high enough dose and get the levels up. And the reason is because you stimulate more receptor sites, which results in better signal transduction and biological activity of that hormone. But yet everyone wants to restrict based on number. They don't need it because their number is not below that magical range. Yeah, but everyone that takes it feels better. Yeah, but they don't qualify for it because of the number. The numbers are meaningless. Next course, we'll look at all of the studies that show numbers are meaningless and they do not predict who's going to have symptoms and who will improve. How do you then figure out who's going to improve? It's trial and error. You give the hormones. And then when they improve, patients want to continue it. I've never seen any man on testosterone. I've never seen any woman on thyroid that says, no, I don't want to take it anymore. I didn't feel good on it. Everyone feels better if you use enough of it. So normal hormone levels are not optimal levels. Normal does not guarantee maximum clinical efficacy or symptomatic improvement. You have to understand that everyone is stuck on normal. No one is stuck on optimal. No one quite understands that you have to be optimal or supraphysiologic in order to get efficacy and to get symptomatic improvement. Most people, unfortunately, do not understand that concept. It's in the literature. We see it clinically, but everyone tends to ignore it, which is unfortunate. So again, in spite of what the literature says, your peers will think you need to stay in the normal range, and they will not understand. So you're going to have to understand how to counter that and explain it. This requires an understanding that it's the receptor site sensitivity, attachment of the hormone, the ligand to the receptor site, and signal transduction inside the cell that results in the physiologic effect. It has nothing to do with the number. So there's so many other factors involved, but the zealots want to use a number to restrict. They want to use a number to say you shouldn't go above that, and they just do not understand. So why does AACE want to restrict hormone administration based purely on numbers rather than on symptomatic improvement? They do it for political reasons, which is very unfortunate. I can't tell you the number of times I've seen the endocrinologist testify, thyroid wasn't indicated, the TSH is normal. DHEA is not indicated unless you have adrenal failure. Testosterone is not indicated. They don't qualify because their level is not less than 300. It's thoroughly amazing that people that should be the experts and know this completely do not know their own medical literature and do not understand hormones, which is a very sad commentary for medicine. But on the other hand, for those of us that understand it, practice it, preach it, it's completely changed our practices. It's completely changed the lives of our patients. So our goal is to restore hormone levels to the normal range of a young adult, optimal, the upper end of that range, and not the normal range of old adults. But more importantly, in every study that I read, is to alleviate symptoms of hormone deficiency. You use the number as a guide, but we want to help improve health and wellness, but we also want to help improve symptoms. And if your symptoms are not improved, but you're afraid of that number, then refer the patient to me and let me fix them. I didn't make this up. I quoted this from one of the articles in JCEM. The ultimate goals are to maintain the highest quality of life, to reduce disability, to compress major illness into a narrow age range, and to add life to years. What a concept. This is out of JCEM. I don't know who wrote this. I couldn't have written it better myself. That should be our goal, but yet that's not our goal. Our goal is to lower cholesterol, lower blood sugar, lower blood pressure. What about the visceral fat? Ignore it. What about subcutaneous fat? Ignore it. Well, but that's the source that's causing everything, and we can get rid of that visceral fat by utilizing hormones. No, we'll just use these drugs instead. It makes no sense whatsoever. They just don't get it. I didn't spend much time on part one on growth hormone because it's a hormone that I infrequently prescribe, and the reason I infrequently prescribe it is because it costs about $1,000 a month, and most people won't afford that. But I want you to understand the literature. I want you to understand it's a hormone, and I want you to see the literature support for it. What happens when we lose it? What happens when we replace it? So this is a little condensed 15-minute lecture on growth hormone. Please do not use the term growth hormone anymore. Change the name of it. It's no longer growth hormone. It's confusing. People say, I don't want to grow. It doesn't make you grow. Oh, yes, it does. That's why it's called growth hormone. And it causes cancers to grow, too. That's why it's called growth hormone. It causes cancers to grow. Get rid of the word growth. Put the word healing in place of it. It's now called human healing hormone, not human growth hormone. Daniel Rudman, back in 1990, in his New England Journal of Medicine article, stated that overall deterioration of the body that comes with growing old is not inevitable. We now realize that some aspects of it can be prevented and reversed with growth hormone, and that's where the term anti-aging came from. Aging is actually a phenocopy of growth hormone deficiency. The same thing that you see with growth hormone deficiency, you sort of see with aging. And if you look at all the studies where they replace growth hormone, even in patients that were not deficient, just regular, average, everyday people, all of these benefits were seen. You improve muscle mass. You reduce visceral fat. You reduce subcutaneous fat. And as a result, you improve lipids, which helps protect the cardiovascular system. It's beneficial for the immune system. It helps healing. Anyone that's immunocompromised, anyone that is diabetic, anyone that has very poor healing would benefit tremendously by being on growth hormone. It helps cognitive function. It helps memory. We'll look at the brain lecture and all the different studies using SPECT scans that look at the thickness and the amount of beta amyloid protein that's on the neurons. And you can reverse it. You can remove it with growth hormone. Yes, it's thoroughly fascinating. There is a medicine that pulls plaque off and improves function. You have to show that it improves function. You have to have some sort of outcome study to show that their memory, cognition, and their function improve. The outcome studies show that it benefits people. When you look at the SPECT scans, you can see how much it removes. It's just thoroughly amazing. We've got this drug that works great for Alzheimer's disease, and we ignore it. Why? Because people don't qualify for it. Why? Because those are AACE guidelines. When you reduce visceral fat, subcutaneous fat with growth hormone, and you increase muscle mass, what's it do to insulin sensitivity and insulin resistance? It reverses it. You don't need to take 3 diabetic medicines. You just need to optimize your growth hormone, lose the visceral fat, lose the subcutaneous fat. There's your treatment for your diabetes. There's circumstantial evidence that growth hormone deficiency and aging overlap. That's why patients love it, embrace it. They want it. Doctors completely resist it. Life without growth hormone is poor, both in quality and quantity. Unfortunately, I wish I could put growth hormone back on the backyard tree where the money tree is, and everyone would have access to it. Average cost is around $1,000 a month. It's absolutely ridiculously expensive, which is why most people won't afford it. But in every study, when we replace it, there's benefits. I can't tell you the number of patients that I've seen over 20 years that have benefited from it. Growth hormone peaks at puberty, and your levels then continue to fall until old age. At age 60, most adults have a 24-hour growth hormone output that is very similar to younger patients that actually have pituitary gland deficiencies and have growth hormone deficiency at a young age. The number of IGF is the same. So if we replace it in young people whose levels are low, then why shouldn't we replace it in older people over 60 who have the same low level? It makes perfect sense. And that's the goal. In a young person that's deficient, we measure IGF-1. That is a protein produced in the liver by growth hormone administration. That's the way we monitor it. You don't monitor growth hormone. You monitor what growth hormone causes, which is a production of a protein in the liver. That protein is called somatomedin, or IGF-1. When we're young, our IGF-1 levels are 400, 500, 600. And when we're older, our level falls to around 100 or less. So the goal of therapy in every study is to optimize IGF-1 level, bringing your level back to around 300. That's the level typically for a 30 to 40-year-old. Almost all adults over age 40 will have IGF-1 deficit and will have a level that will indicate that they are actually deficient and they would benefit from growth hormone administration. Again, because of the cost and the politics of it, I don't prescribe it or recommend it for most people. If people want it, they come to me and request it, then I will prescribe it. But otherwise, I don't recommend it because of the cost and the hassle of doing it. Journal of Endocrinology investigation. The fall of growth hormone secretion seen with aging coincides with changes in body composition and lipid metabolism. So what happens when you get older? You get fat, increase in visceral fat, you lose muscle. When you lose muscle, you lose metabolism. When you lose metabolism, your cholesterol goes up, your HDL falls, triglycerides go up. Increase in cardiovascular disease. So Blackman is now head of NIH. The results from Blackman, he used to be the head of endocrinology at Hopkins. The results that they published showed the positive effects on growth hormone on lean body mass. It increases muscle mass, decreases central and visceral fat and truncal fat, and it decreases LDL cholesterol, and it improves aerobic capacity. Everything that's bad that happens when we get older can be reversed by growth hormone administration. It's a wonderful hormone. It's a wonderful drug. In addition, as we get older, you lose growth hormone. When you lose it, all of these bad things occur. When you replace it, it reverses all these bad things. It improves bone. It improves muscle. It improves exercise endurance. It decreases truncal and intra-abdominal visceral fat. It improves insulin resistance. It corrects dyslipidemia. It's great for the skin, which is why cosmetic and plastic surgeons love it. And it helps improve our quality of life and how we feel and how we function. Now you know why it's so in such great demand. Now you know why books have been written on it. But unfortunately, because of the expense of it, people say, well, I can't afford that. But nevertheless, this is by Mark Blackman, published in JAMA, and this is what happens when you lose it. And these are things that will improve when you replace it. Aging results in significant loss of all of our hormones, and growth hormone is just one of those hormones that you lose. Replacement in adults prevents and treats the clinical syndrome of aging. Don't use it for anti-aging, get rid of the term, but you can use it for helping to improve and maintain quality of life and wellness. This is an article that appeared in JAMA, and it showed that when you lose growth hormone around age 40, somatopause starts around age 25 and is complete by around age 40. Somatopause is the loss of growth hormone when you finally lose enough of it that your level is low enough for you to be deemed deficient. It coincides with the loss of slow-wave sleep and REM sleep that we see as we get older. And when you replace growth hormone, you improve that deep sleep. So the recommendation, which is very interesting in this article from JAMA, suggests that we should replace growth hormone at a younger age. When? Around age 40, which is when you really start to lose a lot of it. Don't wait till age 65 when your body's been exposed to growth hormone deficiency for 25 years. Replace it around age 40 and prevent those changes from occurring. It only makes sense. That's why we optimize all hormones, and growth hormone is no different. Unfortunately, because of the patents and the cost of it, most people cannot and will not afford it. Another study showing when you're losing it and your IGF-1 level falls below a certain level, that's usually around 150, there's increased cardiovascular morbidity and mortality. You lose muscle mass and bone, you increase visceral fat, you get dyslipidemia. Taking growth hormone reverses all of those problems. It is a great hormone. It helps improve body composition. It maintains muscle, which increases metabolism. It burns visceral and subcutaneous fat, which helps prevent insulin resistance, dyslipidemia, and cardiovascular disease. I can't count the number of patients that I've had, probably a dozen or more, that have had congestive cardiomyopathies. I put them on growth hormone. Their cardiac output goes from 15% up to 30%. There's a significant improvement in their functional status. They'll go back and tell their cardiologist the improvement. The cardiologist will measure it on echo to see that their cardiac output is improved. And then when they find out what they're doing, the cardiologist sends the patient to an endocrinologist who says, get off the growth hormone, you don't need that, you don't qualify for it, stop it. And the patient comes back and says, well, I stopped it. How do you feel? I feel like crap. Well, my doctor's told me to stop it. Okay, well, if you want to feel like crap and you don't mind having a cardiac output of 15%, then stay off of it. Yeah, but my doctor said. Your doctors don't understand. It's really a shame. It helps improve quality of life because it reverses the atherosclerotic changes seen in the blood vessels, and it improves cardiac output. It unloads the heart. It decreases systemic vascular resistance. It increases ionotropy to increase cardiac output. What drug does that? There is not one. But this works great, I know, but too bad because people don't qualify for it based on guidelines. We'll go over the prescribing it and monitoring it and how to define the deficiency on another section. So quality of life improves. You can reverse carotid intermediate thickness. I addressed this a little bit in part one. Now we've got the PCSK9 inhibitors that run about $15,000 a month. That combined with maximum statins does reverse plaque. Recent studies showed that in order for the PCSK9 inhibitors to be cost effective, the price needs to be lowered to around $4,000 a year. At the current cost of $15,000 a year, it makes no sense to use it, which I absolutely agree. But what else can we then do to reverse plaque? What drugs reverse plaque? What else? What other studies have shown plaque reversal? The other studies that show plaque reversal are 2 milligrams of oral estradiol. It's too bad you can't use estrogen because you're supposed to use it for the shortest period of time in the lowest dose and then stop it. Yeah, but what about the plaque reversal in the carotids? Don't you want that? No. Really? No. But that doesn't make sense. Yeah, but that's what ACOG and NAM says. Lowest dose and stop it. Yeah, but what about all those reversal effects? What other drugs reverse carotid intermediate thickness? Testosterone. There's a recent study that just came out, published in JAMA Internal Medicine, that showed that in men that took androgel for 1 year, the amount of soft plaque increased. Cardiologists have jumped on this and said everyone's got to stop taking testosterone because of the increase in soft plaque. Well, when you look at the study, the way that they measured the soft plaque is questionable. That's why you don't look at soft plaque, because it's not predictive. But when they saw that, they say, oh, increase in soft plaque, that's bad. What's been shown to be predictive is hard plaque. It's the calcified plaque. What happened to the calcified plaque? It decreased. Not much, but it did decrease. But when you look at all the other studies where they used good doses over long term, every study shows reversal of calcified plaque, both in the carotid as well as in the coronary vessels. Every study shows that. But yet this study shows an increase in soft plaque, so now the cardiologists say, okay, well then you got to stop it. But when you stop it, what happens? You increase your hard plaque. The way to reverse your hard plaque and decrease coronary calcium scores is with testosterone in high dose over long-term effect, over long term. But yet everyone's a reactionary. Oh, this study showed increase in soft plaque, everyone's got to get off of it. If you look at that same series, there was another series that looked at outcomes. What did the outcome studies show in men that took the testosterone? Yep, decrease in MI, decrease in cardiac events. So if you stop the testosterone because you fear the increase in soft plaque, what you're actually doing then is increasing MI and increasing hard plaque and calcified plaque. You completely didn't even look at the other secondary study that was an outcome study that showed decrease in heart attacks. Why don't you look at that outcome study? Why is it you looked at soft plaque that is meaningless? That's a reactionary effect as opposed to an analytical effect where, well, yeah, there was an increase in soft plaque, but that pretty much has no prediction. And the way they looked at it and the way they monitored it and the way they diagnosed it is questionable. So it's an interesting study. That's it. It's an interesting observation. That's it. What about all the outcome studies? The outcome studies show decrease in MI in every study except for those flawed studies. What about calcified plaque? Decrease in every study. What about carotid intermediate thickness? Decrease in every study where they looked at it. The benefit of testosterone in decreasing hard plaque and coronary events is tremendous. And yet, what are the cardiologists calling for? You stop it. That's a reactionary. They're completely clueless and don't understand all the benefits that they're losing and missing when they stop it. It makes no sense. They just don't get it. Growth hormone has profound effects on the CNS. We'll look at this in the brain studies. It enhances cognition, memory, alertness, motivation, work capacity. It does cross the blood-brain barrier, and of course, when you look at the SPECT scans, it reverses and removes beta-amyloid protein. What a great drug it is. And yet the Endocrine Society says you don't qualify for it. Your level's not low enough. I don't care what the level is. All the studies looked at not levels. All the studies looked at, we'll give it to people with Alzheimer's disease and see what happens. And it reverses the plaque. It's amazing what it does. It's amazing what we ignore and denigrate. IGF-1 levels correlate with cognitive function. The higher your IGF-1, the better your cognition and memory. The lower your IGF-1, the worse your cognition and memory. Where would you like your levels to be? I want mine to be high. Well, how do you get the IGF-1 level high? You got to take growth hormone. Yeah, but I didn't qualify for it. I don't care. Get rid of the qualification. Get rid of trying to be painted into a corner by AACE guidelines. Use the numbers as a guide to therapy. This is from JCEM, our Bible of Endocrinology. People that have low levels have poor emotional and psychological functioning. Why would you not want to improve that? Well, they don't qualify for it. They don't qualify for better enhancement of memory and cognition. IGF-1, that goes up when you take growth hormone, protects against beta-amyloid-induced cell death and deposition of beta-amyloid protein. Journal of Neuroscience. What is it that we don't understand about these studies? Why is it we ignore it? It's absolutely thoroughly amazing what we ignore. Growth hormone improves bone. Yes, it does cause bone to grow. It's 6% increased bone density. Estrogen is 2% per year. Growth hormone is 6% per year. I've had people that have had DEXA scans of -4, -5, -6. 10 years of being on growth hormone, their DEXA scans are now less than 1.5, less than 1. They have completely reversed all of their osteoporosis. And there's no drug that does that. Bisphosphonates do not do that. Bisphosphonates slow down your loss. They don't improve bone density. The only thing that improves bone density are hormones. Estradiol, testosterone, growth hormone, and vitamin D, which is also a hormone. Another bone density study and bone mass study, growth hormone helps improve bone density. It helps improve muscle mass. It decreases fat mass. Essential, no side effects to the doses that we use. My criticism is the orthopedic industry. Little old lady falls down, breaks her hip. Put a pin in it, throw her in a nursing home. She never gets up and walks again. You give her nothing to help that bone heal. You give her nothing to help the muscle, ligaments, joints, tendons around that bone to heal and get her butt back up and walking again. You've done absolutely nothing to help the anabolic function of that person. The orthopedist response is, that's beyond our scope of practice. That's not my responsibility. Well, whose responsibility is it? It's each and every one of our responsibility. Why did they do this study? And what should we take away from this study? There's tremendous benefits to it. We just simply ignore it. It is really a shame. Another study looking at carotid intermediate thickness. It is amazing. It was published in JCEM. What it does to the carotids, it reverses calcified plaque. It shrinks plaque. There's no drug that does that. Well, now with a PCSK9, yeah, it does. But the side effects of maximum statin, in addition to this drug, in addition to how much it costs, and still, we don't have any outcome studies. We've got outcome studies with growth hormone. It reverses plaque, and there's outcome studies to show decrease in heart disease and a decrease in death. We'll look at that next section on outcome studies. Growth hormone deficient adults have increased cardiovascular mortality. Inflammatory markers are predictive of these coronary events, and growth hormone completely reverses these cardiac markers. It reverses C-reactive protein, which is pretty much dependent on visceral fat, and that's how growth hormone works, a decrease in visceral fat. Visceral fat decreases, subcutaneous fat decreases, there's improvement in all lipids and lipoproteins. What a tremendous, great drug it is, and it's completely ignored by mainstream medicine. Not only is it ignored, but it's denigrated by it. It's really a shame. It's too bad. Increase in contractility, increase in cardiac output. In patients with congestive cardiomyopathies, their symptoms improve. They feel and function better. Doctors take them off the growth hormone. Oh, you don't need that. Oh, something bad is going to happen. Like what? There's nothing bad that happens. What happens is when you stop it, it's really a shame. Another study, JCM, improvement of muscle mass, improvement of cardiac output, strength and body composition improves. When you lose growth hormone, your cardiac output falls. When you replace it, it improves. Absolutely amazing what it does, and it's completely ignored. If we could come up with a drug that would do that, the cardiologist would prescribe it like crazy. Growth hormone? No, we ignore it. Another study, increase in ejection fraction, cardiac output, an improvement in cardiac remodeling. What a great, tremendous drug it is. Everyone with a heart attack or cardiac disease should be on it. You can't be on it because insurance isn't going to pay for it, and it's too expensive, which is really the shame. It helps improve glucose metabolism, improves lipid profile. Look at these studies. Why do we ignore them? What is it that we don't understand? We fear the unknown, and it's really a shame that we ignore the data. Growth hormone deficiency, abnormal body composition, long-term replacement normalizes these abnormalities in body composition, fat mass, subcutaneous mass, muscle mass, strength, endurance, cardiac output, dyslipidemia, cognition, memory. What a great drug it is, and we simply ignore it. It is really a shame. They just don't get it. Growth hormone was administered to people that had abdominal obesity. What happens? They decreased visceral fat, lost trunk fat, lost subcutaneous fat, improvement of all lipid and carbohydrate markers. Another side effect, decreased diastolic blood pressure. That's why it reverses carotid intermediate thickness. That's why statins don't. Statins do not affect visceral fat. There's a slight increase in insulin resistance and diabetes with statins because of the increase in visceral fat. Why do you get an increase in visceral fat? With statins, what's it do to your testosterone level? It cuts it in half. When it cuts it in half, what's it do to sexual function? Now you know why you can't get it up. Now you know why you don't want to get it up, because you have no testosterone and your libido falls. But we got to get that cholesterol level down. You can accomplish the same lipid benefits with testosterone without all the side effects and problems and complications that you get. Absolutely amazing. They just don't get it. This is a study from JCM looking at a baseline level of IGF-1 of 100, which is what most adults have over age 40. It'll bump your level up to 313, and over 5 years down to 268. You get a little bit of tachyphylaxis as you get older. 5 years resulted in improvement in all aspects of body composition. Lean muscle mass improved. Bone mineral density improved. HDL improved, it went up. Everything else went down. All the bad guys went down. All the good things went up. What a great drug it is. It's safe and it's well tolerated. Then what is it about it that we don't grasp? We don't grasp it because the AMA and the FDA denigrates it because it's used and abused by adults. Used and abused? accomplishing all these things is abuse. Deficiency, we don't feel or function very well. Replacement, we feel and function so much better. Improvement of quality of life, improvement of sense of well-being. I guess AACE and FDA doesn't want that. But if you look at these journals, look at the journals showing the benefits. And why is it that we ignore that? It makes no sense. Wound healing. It's a healthy hormone for beneficial effects on tissues. For those diabetics that don't heal, everyone should be on growth hormone. It is really a shame that it's not FDA approved for that, because it certainly should be. Low dose treatment combined with dietary restriction improves muscle mass and a significant decrease in obesity in type 2 diabetes. It is a fascinating, great drug in patients that are obese, and nothing else will work, and it works tremendously well. Another study showing improvement in lean body mass, decrease in fat mass, decrease in waste, and an improved quality of life. What a great drug it is, and you wonder why people scramble and insist on being treated with growth hormone, because of the benefits of it. Feel-good-wise, health-wise, you really can't beat it. Increase in cardiac performance, increase in our structure, decrease in visceral fat 46%? Really? What are the cardiologists doing to reduce visceral fat? Absolutely, entirely nothing. Fred, you got to lose weight. Martha, got to go on a diet. Okay, doc, thanks. Thoroughly amazing what we ignore. Growth hormone treatment for 10 years results in improvement of muscle mass, improvement of lipids, a decrease in carotid artery intermediate thickness, and an improvement of well-being. What a great drug it is. No side effects, problems, complications to it. Now you understand my passion for hormones. Now you understand my passion as to they just don't get it. Why is it that they don't get it or understand it? They just don't grasp it. They're reactionary as opposed to analytical. Growth hormone is essential for adult life. Without it, life is shortened. Quality of life is reduced. The medical case for growth hormone replacement is now proven beyond any reasonable medical or scientific doubt. Growth hormone IGF-1 research. Let me just briefly review testosterone. Men and women lose testosterone as they get older. According to recent FDA guidelines, that is not reason enough to prescribe it. So just let them suffer? Yes. Yeah, but they feel better when they take it. They don't qualify. So they're just supposed to live that the rest of their life not feeling well? Yes. I mean, we're supposed to ignore the thousands of medical journal articles that show there's a benefit to it? Yes. And we just let them get old and fat? Yes. And die from cardiovascular disease? Yes. And depression? Yes. And have no sexual function? Yes. And no libido? Yes. And you call yourselves good doctors? Yes. I hope you enjoy my sarcasm, because what we do and what they do makes no sense based on the medical literature. About 10, 15 years ago, I had a collection of about a dozen additional journal booklets that were put out by the major medical journals, OBGYN, Menopause, AACE, Journal of Urology, that address the issue of testosterone in women. It is thoroughly amazing the number of studies out there that show benefit, and it's thoroughly amazing our medical societies can't get together to get an FDA-approved drug to help improve quality of life that's shown in all of these studies. It just irks me. Does testosterone decrease with age? It does in everyone. But yet, those are not FDA indications. The fact that your testosterone level falls with age is not an indication based on recent FDA guidelines that are trying to restrict. Really? Yeah. So I have to live like this forever? Yeah. And life sucks? Yeah. And so I don't qualify for it. No one's going to give it to me because my level's not less than 300. That's correct. Well, for the last 20 years, we didn't have that restriction. That's correct. So why do we suddenly have it now? Because that's the way it is. Because the FDA is trying to restrict it. Yeah, but that doesn't make sense. Yes, I know it doesn't make sense, but that's reality medicine. Sorry. Yeah, but what about all the benefits that I'm going to lose if you don't prescribe it for me? That's tough. What about women? The same benefits in women are the same benefits in men. They're no different. They derive benefit from it also. So this was that questionnaire that was the ADAM score. And if you had these symptoms, that you would benefit from testosterone. And I don't know anyone over age 40, man or woman, that does not suffer from fatigue, depression, loss of memory, loss of sex drive, difficulty with erections, difficulty with sex, loss of erections. That was the test that I used to use. If you do not wake up with a morning erection, your testosterone level is too low. Welcome to 30hood. Decreased intensity of erection. So when I was on testosterone, my orgasms were much better, and now, doctor, since you took me off of it, I don't feel anything. Can't you put me back on? No, you don't qualify. You mean I got to live like this forever? Yeah. Well, that sucks. Yeah. Well, what do you mean I don't qualify? Why don't you want me to have a better sex life? Because you don't qualify for it. How is it that I don't qualify for it? Well, under new FDA guidelines. Interesting, isn't it? It makes no sense why they recommend what they recommend based on the literature. When you lose testosterone in men, it's the same effect as when you lose estrogen in women. There's an adverse effect on our health and wellness. And 90% of men and women will die from cardiovascular disease, which you can protect against by optimizing your hormones. But yet, they just don't get it. They don't grasp it. Later in part 2, we'll look at all the benefits to replacing estradiol and protection against cardiovascular disease, and how we don't want to extrapolate the harm of Premarin and Provera to estradiol progesterone. We'll also look at the benefits for cardiovascular disease protection with testosterone in all of those studies, which we tend to ignore, which is very unfortunate. That's a reactionary effect. Oh, it increases soft plaque, you shouldn't use it. Yeah, but what about the other 5,000 studies that showed benefit and decrease in MI? Well, we're going to ignore those. Yeah, but those are randomized controlled trials. We ignore them. Well, what about all the meta-analysis of all the randomized controlled trials that showed benefit? We're going to ignore those too. Yeah, well, that doesn't make any sense. Yeah, I know. Then why do we do it? They just don't grasp it. The male menopause is less sudden than the female menopause, but it's just as severe as the long-term consequences. You simply replace it, the testosterone, back to the levels of a young adult, and for symptomatic improvement. There's an increased risk of heart attacks and strokes in men and women that lose hormones. There's loss of brain function, cognitive properties, and an increase in Alzheimer's disease. It's thoroughly amazing. Alzheimer's disease is a billion-dollar disease that can be prevented with hormones, and we simply ignore it. Oh, if I could become Surgeon General. Loss of drive and competitive edge. We just get tired, want to come home, lay in the chair, not move. Falling level of fitness. I don't have strength or energy to go work out. There's decreased effectiveness of workouts when you lose your testosterone. And all this can be completely reversed by optimizing your testosterone in both men as well as in women. Same thing. Women also will become depressed, fatigue. Testosterone reverses that. We saw that in the part 1 articles from JAMA and the New England Journal of Medicine. As far as sexual function, we've already reviewed all of that. Intensity of orgasms. Everyone loses it as you get older. The only way to get that back is to optimize your testosterone level. And all of these guys out there, it's got to be guys, making these decisions on trying to limit testosterone availability to men, I wonder how many of them are not on testosterone. So how's your loss of orgasmic ability working out for you? They got to be sneaking it. They got to be sneaking it. They got to know. They got to understand. It's just really a shame. Better sexual function, better erectile function, better orgasmic function, and I'm not talking just for men, also for women. It's not related to dose or method of delivery. It has to do with optimizing levels. If you still don't see an improvement, you've got receptor site resistance that needs to be overcome by higher doses. The literature supports that. Sometimes you need to be very much supraphysiologic in order to improve symptoms. Testosterone has the same effect in the brain as does estrogen in the women, probably because of the aromatization of testosterone into estradiol. Testosterone protects and reverses beta-amyloid protein deposition. Every study shows the same thing. Why is it that we ignore it? Well, they don't qualify for it. They don't qualify for protection against Alzheimer's disease? Please explain that to me. How do they not qualify? Well, the numbers are not low enough. It has nothing to do with numbers. It has to do with optimizing levels and protecting that protein from being deposited. JCEM. Testosterone correlated with cognitive function and improves it. The lower your level, the greater your risk of cognitive decrease. The higher your level, the greater protection and decrease in Alzheimer's disease incidence. Mood, depression will improve with testosterone administration. Antidepressants do not work in men, sorry. Maybe a few. But what does antidepressants do to sexual function and erections? Kills it. Well, that's great. Probably the reason we have the depression and dysthymia in the first place is because we have the sexual dysfunction. And now we're going to take a drug that makes it even worse? And we call ourselves good doctors? Yeah. It makes no sense whatsoever. Testosterone is associated with fatigue, loss of sense of well-being. Higher levels improve fatigue and improve energy. Higher levels. Did they see any improvement in these studies where the total testosterone level went from 300 to 400? No, of course not. Would you expect to see any improvement? No, of course not. Yeah, but that was the result of the study. Look to see what the study says. Look at what the numbers are. Look at what they used, and it makes perfect sense why it didn't work. But that doesn't mean that other doses in other people and optimizing it will not work, because all the literature shows it does. It's another study that should be trashed. Reactionary said, aha, see, it didn't work. Analytical thinking says, well, of course it didn't work. Anyone can make sense out of that. But all the other studies show that it does work when you optimize it. Men with heart disease had significantly lower testosterone levels. Every study shows when your level is low, there's an increased risk. Every study shows when your level is high, it's protective. Acute administration causes an improvement of endothelial function. That's the key, endothelial function. And that's what we don't quite understand or grasp, is the importance of nitric oxide release with the use of testosterone. American Journal of Cardiology. Intracoronary injections causes dilatation. It unloads the heart. It is vasodilatation. That's why there's a decrease in ischemia, both on treadmill testing as well as symptomatology. There's a coronary relaxing effect in testosterone, medical journal circulation. In men that have heart disease, bad heart disease, ischemic heart disease will benefit from testosterone. All the cardiologists are saying, no, you got to get off of it. Yeah, but when I got off of it, I didn't feel as well. You're right. My angina got worse. You're right. And so is your deposition of plaque going to get worse. And so is your calcified ASVD going to get worse when you stop it. Yeah, but my doctor scared me. Your doctor's clueless, with all due respect. Testosterone decreases fat mass. Testosterone and estradiol correlate with bone density. Don't lower estrogen. Don't block it, as I've preached. In part 3, we'll look at all the studies to show harm when you block aromatization in men. Replacement improves insulin sensitivity. Protects against diabetes. Protects against syndrome X, hypertension, diabetes, fibromyalgia, coronary artery disease. It protects against it. Look at what the studies show. Why would you not want to protect against it? Well, they don't qualify for it. Really? They don't qualify for all this protection? It's just absolutely amazing what the FDA and the AACE have done by the recent political restrictions against the use of testosterone. It's important for the sense of well-being in women. It helps improve strength, muscle mass, libido, sexual function, clitoral sensitivity, just like erectile sensitivity and orgasmic function in men. Body composition, it helps maintain muscle and burn fat. It's anabolic, muscle, ligaments, joints, tendons, bones. And yet it's not approved for women, and AACE says we don't recommend it for women. You don't recommend all those things for women? No. You don't recommend this for your wife? Well, maybe that's different. But we don't recommend it for the public. Shame on you. Improvement of sexual function, improvement of psychological well-being, we saw that in part 1. Testosterone should be FDA approved for all women over age 40 that have symptoms of a deficiency. It makes no sense. It's not just a sex hormone. It's needed for energy, strength, cognitive function, and of course for sex too. It's the feel-good hormone of both men and women. When you lose estrogen, you will have an adverse effect. And every study shows an increased risk of heart disease, strokes, osteoporosis, fractures, Alzheimer's disease, dementia, urogenital atrophy, chronic urinary tract infections, depression, mood swings, sleep disorder, macular degeneration, loss of vision, loss of tooth, memory loss. That's what happens when you lose estrogen. Oh, but you shouldn't replace it. Use the lowest dose for the shortest period of time and then stop it. And when you stop it, you want to increase the risk of all these things? Is that what you're saying? Well, that's what ACOG and NAM says. That's because ACOG and NAMs don't get it. They can't extrapolate. They don't understand the benefit and protection with estradiol and progesterone. And they extrapolate the harm of Premarin and Provera to estradiol and progesterone. They shouldn't. The literature supports the opposite. But because they're funding, and unfortunately their connection with Big Pharma, they still have to continue to promote Prem-Pro, and as a result, they use low dose, shortest period of time, and stop it. Yeah, but then, you mean I got to suffer with all of these things? Yes. But that makes no sense. Yes. Well, that's ridiculous. That's reactionary. They don't get it. I just read another article out of a urology journal that questioned the safety of testosterone, and the purpose of the article was to show that testosterone was very safe. But it was interesting. They said, well, we don't want to make the same mistake with testosterone that we made with estrogen, thinking that estrogen was beneficial, and now we realize that estrogen is harmful. Really? You think estrogen is harmful? Well, yeah, that's what the WHI trial showed. Really? You can't figure that out. Well, yeah, it says lowest dose, shortest period of time, and stop it. That's what the recommendation is. They don't get it. They can't understand the benefits of estradiol and progesterone and the lack of harm of it. And they just don't get it, which is really a shame. It's a sad commentary. When you lose estrogen, you'll get vaginal atrophy, chronic urinary tract infections, changes in your skin, bones, breast, fatigue, loss of libido, urogenital atrophy, making sex difficult. You lose the anti-aging effects on your tissues and on your well-being. And you don't want to take it. Well, my doctor told me to stop it. It was going to cause a heart attack or a stroke. Really? That's what your doctor said? Yeah. He cited the WHI trial. They just don't get it. By the end of part 2, you will get it. You'll look at all those studies, and you'll look at the comparative studies, and then you'll finally come away with, you cannot compare them to be the same. And when you do, you'll completely miss it. The benefit of estrogen. Now women are demanding the natural estradiol instead of the synthetic hormones. Studies show that Premarin was beneficial for 30 years. But most recently, there's an increase in blood clots. We'll look at that in the next section. The incidence of blood clots with Premarin. There is a slight increase in incidence. What is the incidence of blood clots with natural estradiol? There's good, big NIH studies. The first one was the West, then the Cora, then the EPAT, that showed reversal of plaque, then the Danish, then the Kronos, or the KEEP study, then the ELITE study, all using oral estradiol. Any increased risk of strokes, heart attacks in any of those studies? No. Increased incidence of blood clots, DVTs, PEs? No. Then where's it come from? Well, the WHI trial, no, that's Premarin. Well, you have to assume it's the same. No. If you assume it's the same, you will assume incorrectly because the data in the studies show don't assume. The one article published in JAMA showed that there is an increased risk of blood clots with Premarin in the first year of taking it, relative risk 1.8. The relative risk of oral estradiol was 0.9. That was a comparative study. Progesterone did not increase the risk. The risk was still 0.9 with oral estradiol. It goes up with Premarin. It goes down with estradiol. Well, but you have to assume the risks are the same. No, that's a reactionary. If you're analytical and you look at all the studies, you will analyze they're not the same. And the study showed complete opposite. Natural HRT provides all the benefits of HRT without the side effects, problems, and complications and blood clot issues associated with Premarin. Pertinent was used for decades. There are some side effects and problems, and that is because of the first-pass effect going through the liver, increasing clotting factors. But it's really the increase in estrogenicity. Pertinent is 15% estradiol. It's about 50% estrone, about 30% equilin and equilenin, which do cause blood clots, and about 10 extra estrogens also that have clotting factors. So all of those estrogens added up increase significantly the potency or estrogenicity in the liver of increasing those blood clots. We do not see that with estradiol. Therefore, natural estradiol and progesterone have evolved with the human. We should use those steroids. We should not use the synthetic, and don't extrapolate the harms of CEE, MPA to estradiol and progesterone. Unfortunately, mainstream medicine does. They shouldn't. Synthetic HRT does have some adverse effects. The first one to study this was Hargrove et al. That published their findings in the Infertility and Reproductive Clinics of North America, where they used the bioidenticals and found pretty much no side effects, problems, or complications in comparison with the synthetics, and significant side effects with the synthetics that you did not see with the bioidenticals. Progesterone is, again, very confusing for most practitioners. If you look in the PDR, it says in the PDR, under Prometrium, the same write-up as for Provera. It shows that Prometrium increases breast cancer, heart attack, strokes, blood clots, DVTs, and PEs. It increases side effects, problems, and complications, identical to that of Provera, because the write-up is identical to that of Provera. But that's not true in any study. Yeah, I know. But then why did they say it? Because they could. And now you see the confusion. There's tremendous health benefits. There's many feel-good benefits. There's absolutely no reason not to give progesterone to all postmenopausal women or premenopausal women that need it for symptom improvement. More importantly, there's progesterone receptor sites throughout the body, not just in the uterine tissue. There's receptor sites in the breast, brain, bone, vaginal epithelium, blood vessels. Progesterone is synergistic with estrogen. Progesterone is antagonistic and moderates many of the side effects of estrogen, mostly the fluid retention, the bloating, the swelling. So it is a great drug. It is a hormone. It has none of the side effects, problems, and complications as the synthetic progestins. Again, Hargrove et al. Titrated progesterone to premenopausal levels, which was 10 or greater. They found no endometrial proliferation with a level of 10, and the dose that they used was 200 milligrams oral capsule. Progesterone is beneficial in reducing symptoms of menopause, reducing symptoms of perimenopause, reducing symptoms of PMS. It protects against uterine cancer, breast cancer. We'll see the effects on breast cancer when we look at Part 2 cancer section. It helps the bones. It helps the cardiovascular system. It was the PEPI trial that put micronized progesterone on the map, because in this study they looked at micronized progesterone versus Provera. With Provera, decrease in HDL, increase in plaque deposition, increase in inflammation, increase in MI. With progesterone, slight increase in HDL, none of the adverse effects that you see with Provera on the vasculature, clotting, etc. So that's where Prometrium and micronized progesterone got put on the map, was in the PEPI trial that showed cardiovascular protection as opposed to Provera that we know antagonizes or reverses all of estrogen's beneficial effects. Progestins cause depression, swelling, breast tenderness, bleeding, weight gain, increase in insulin resistance, increase in diabetes, increase in visceral fat, and a significant increase in breast cancer. The only organ that progestins like are the uterus. All other tissues, organs, and systems, progestins don't like and have an adverse effect. You see none of this with micronized progesterone, but yet mainstream medicine completely ignores all the studies to show benefit. I'm still looking, and I've been looking for 20 years. I'm still looking for that study that showed that micronized natural bioidentical progesterone is harmful in some way. I haven't found it yet. It's been beneficial in every study. Progestins, uncomfortable side effects, problems, and complications that you do not see with micronized progesterone. Therefore, it's the natural estradiol, the natural progesterone that should be used in contrast to Provera. It has all these side effects and problems and complications associated with it, but when you look in the PDR, they are absolutely the same. But nobody's going to go back in and change that, which is very unfortunate. So you have to use your medical literature and your studies and your data to show patients, show the doctors, they are not the same. They are completely different. So in my practice, I use bioidentical hormones metabolized by normal metabolic pathways that avoid the problem causing metabolites. It is the best preventive medicine. That's why we do what we do. So this is the end of section 1. I will now move on to section 2. The title of section 2 is Hormones and Longevity. Do hormones improve or increase longevity? And do loss of hormones decrease longevity and increase morbidity and mortality? I was lecturing in China about 10 years ago, and it's a very interesting medical society that they have over there in that you have two completely different medical philosophies. The old traditional Chinese-based medicine and the new Western medicine. In the conferences where I teach, it's very interesting that, and I have to lecture through a translator, one half of the class is split. All the naturopathic, natural, traditional trained Chinese doctors will sit on the left side, and all the Western trained doctors will sit on the right side. And they sort of butt heads. They are in conflict. If you are sick and you go to a traditional Chinese doctor, you can be admitted to a traditional Chinese hospital where they will use only traditional Chinese methods. There's no surgery, there's no drugs. It's just herbs, acupuncture, and many different modalities that they have. And it has nothing to do with Western medicine. When you get admitted to a Western trained physician, to a Western style hospital, there's no traditional Chinese medicine that's used. It's only Western surgery and drugs and conventional medicine. Well, one Chinese doctor that was the traditional trained doctor, and I do bond well with them because they think that hormones are natural and replacing them is beneficial. He said, you know, you're talking about anti-aging. He says, do you have any data to support that hormones make you live longer? And I go, well, yeah, there's lots of studies to show that. And he said, where's the studies? And I went, well, they're all over the place. And he goes, show me. And I go, oops, don't have that. So for the next 5 years, I've accumulated studies to show and prove that hormones will improve longevity and loss of hormones will decrease longevity. Where would you like your levels to be? Should you be on the hormones or not? I find it so very fascinating that I hear endocrinologists teach, preach, and testify to the hormones were not indicated because the levels were normal. Yet in every study it shows that normal is not optimal, and keeping your levels normal will result in significant morbidity and mortality and an increase in cardiovascular death when you keep your levels normal. Whereas in every study when you optimize estradiol, progesterone, DHEA, thyroid, and testosterone, there's health benefits to it by decreasing morbidity and mortality and extending longevity. So let's look at those studies. And then I will ask you to ask yourself, where would you like your levels to be? Where would you like your levels of your patients to be? Where would you like the levels of your significant other and your family to be? So this is section 2 of the science of creating health. For maximum health, where would you like your levels to be? AACE and the Endocrine Society still say, if your hormone levels are normal, you don't need hormones. They're still stuck on normal. They completely reject receptor site sensitivity, receptor site attachment, loss of signal transduction inside the cell, and decrease in effectiveness of the hormone that has nothing to do with serum levels. For maximum health, your level should be optimal. This is a review of the opinion of the AMA that was from their annual meeting of the House of Delegates in 2009. And they addressed the use of hormones for anti-aging. Remember, you cannot and should not make unsubstantiated claims publicly in your websites, in any mailings that you send out, or any advertisement that you use. You have to go by the same standards that the drug companies have to go by. And I know you don't like that because you can look up bioidentical hormones in your town and you can find 100 different doctors that are doing bioidentical hormones that are making unsubstantiated claims. And you say, well, it's not fair that they can make the claims and I can't. Well, you can, but I'm not going to come defend you. I got too many of those cases that I'm defending now because somebody wrote a nasty letter to the medical boards. The medical boards went on their websites and they reviewed that what they're doing is making unsubstantiated claims for hormones, bioidentical hormones, and for anti-aging. You cannot and should not make those claims. This is what they have to say. Well, let's get back to the FDA approval. You cannot advertise or make claim, and the drug companies cannot, for any drug other than for its FDA approval. Estrogen has FDA approval for treating menopause. It is also FDA approved to prevent osteoporosis. You can only make those claims. It is FDA approved to treat symptoms of menopause and prevent osteoporosis. If you say anything other than that and make claims to it, you are violating FDA guidelines. The drug companies cannot make any claims. You cannot make claims either for any other hormones. Testosterone is FDA approved for treating hypogonadism. That is the only claim that you can make. Thyroid is FDA approved for treating hypothyroidism. That is the only claim that you can make, and you should not make any other claims. And if you do, you may end up having to defend yourself and go before the medical board, which is very expensive. So this little section here is to show you and prove to you that it is true. You cannot and should not make anti-aging claims because nothing is FDA approved for anti-aging. How do you define anti-aging? There's no definition. Well, if you can't define it, then how do you study it? You can't. Is there any study that showed any hormone was beneficial and FDA approved for anti-aging? Nope. Why? Because they didn't study it. Why? Well, there's no money, number one. Number two, they don't have a definition of anti-aging. Well, if you don't know how to define it, how do you study it? Well, if you can't study it, you can't make the claim. And if you make the claim for anti-aging, you're violating FDA standards. So let's look at what they say. Current evidence fails to support the efficacy of growth hormone as an anti-aging therapy. I absolutely agree. There's no study that is showing that growth hormone is FDA approved for anti-aging. Don't make that comment, don't make that claim, don't make that statement. What did I show you in the last hour about benefits for growth hormone? Tremendous benefits. Can't you state those? No. You can tell a patient that. You can write it in a book like I did, but you cannot use it for advertisement. You cannot hand it out as advertisement to a patient to try to attract them to doing hormones based on false advertisement. So you cannot make that claim. No hormone has ever been tested and FDA approved for anti-aging. No drug has been tested or approved for anti-aging, so you cannot make any anti-aging claims. DHEA as an anti-aging supplement shows no meaningful benefit. We looked at all the studies showing health benefits to DHEA in Part 1. That statement is ludicrous. There's a tremendous beneficial effect of DHEA on health and wellness, but true, not for anti-aging. I absolutely agree with them. Don't make anti-aging claims. Well, then can't you then make the claim as to what has been shown in the medical studies? No, you can't, because when you do, you are then enticing a patient to take hormones based on your enticement because studies showed. You cannot do that. You cannot say that. Yeah, but it's the medical literature. Yes, but you're also advertising something that is not FDA approved for that indication or that use. The definitive evidence of the value of testosterone as an anti-aging therapy in older men does not exist. True, it has never been studied for anti-aging. We don't know how to define it, and we don't know how to study it. Don't make the claim. Did I show you studies of benefit? Tremendous benefits. What happens when you lose it? Tremendous deterioration. You can make the claims of what happens when you lose it. You just cannot make the claims of what happens when you replace it. The long-term use of estrogens with or without progestins causes more risk than benefits. I absolutely agree with that statement. I would never ever use estrogen along with a progestin. And as you know, when I use the term estrogen, I'm referring to Premarin. When I use the term estradiol, I'm referring to estradiol. I don't use long-term Premarin, and I certainly don't use long-term progestins, and I agree they cause more risk than benefit. However, that doesn't mean that you should ignore the plethora of data showing benefit to estradiol, the plethora of data showing harm of progestins, and the plethora of data showing benefit and safety of progesterone. But you cannot make those claims or those statements publicly. There's no credible scientific evidence that exists for the so-called bioidentical hormones. I disagree with that because all the articles and studies that we looked at in part 1 are bioidentical estradiol and progesterone and bioidentical testosterone, but they're not compounded. So just because there's benefit in the studies does not mean that you compounding it is the same. And as a result, you cannot make or state those claims. Compounded bioidenticals are not FDA approved, therefore you cannot make or should not make any claims to superiority of bioidentical hormones over the synthetics. Yes, I know all the studies showed that, but it's not FDA approved for that, therefore you cannot make claims or statements that bioidenticals are safer than the synthetics. We all know they are. We all know the harm of the synthetics. We all know the benefit and safety of the bioidenticals. But you cannot make those claims because what you're prescribing is not the same as that what they used in the study. And again, if you make that claim and you mislead the patient to taking hormones, then the medical board and the FDA can come down on you and state, you made the statement that the study showed and that enticed the patient to take the hormones, and as a result of your enticement, they took the hormones, which could be harmful. The FDA still thinks and claims that hormones are harmful based on those studies. Despite the widespread promotion of hormones for anti-aging purposes, you cannot make or state that claim publicly. You can tell the patient that, but you can't write it in anything that you hand out to them. The scientific evidence to support these anti-aging claims for HGH is lacking. I absolutely agree. There's no study that showed that HGH did anything for anti-aging. On the other hand, what did it show? Growth hormone review section 1. Growth hormone is beneficial for everything. As you get older, all the bad things happen. Growth hormone helps reverse those bad things. Don't make claims for anti-aging. That doesn't mean it doesn't work, and it doesn't mean you can't prescribe it or use it. Don't advertise it. Estrogen for the prevention of chronic conditions is not recommended. I agree. I don't use estrogen in the form of Premarin to treat chronic conditions. That doesn't mean I don't use estradiol, because every study shows benefit and protection. Every study shows harm when you lose it. Every study shows benefit when you replace it. Estradiol is not Premarin. Don't extrapolate them to be the same. But now you understand why they say. Current evidence does not support the use of testosterone at all in older men. Really? No, it doesn't support the use of it because they make these claims that it's not beneficial for anti-aging. It's very unfortunate that is their logic, but that doesn't mean you can't use it, and it doesn't mean that it's not beneficial. Based on available scientific evidence, the FDA, the Endocrine Society, American Academy of Endocrinology have taken positions that there's no justifiable reason to use growth hormone for anti-aging. I don't use it for anti-aging, but I use it to help improve health and wellness and decrease visceral and subcutaneous fat and restore our structure and help how we feel and function. That's what I use it for. I don't use it for anti-aging. Use of DHEA as an anti-aging supplement should be discouraged. Why? Well, because it's not approved for anti-aging. Yeah, but look at all the different things that it does. Well, then use it for all those different things. Don't use it for anti-aging. It's thoroughly amazing that they completely ignore the medical data in the literature. So now let's look at studies looking at longevity. This is a nice study looking at reduced longevity in brothers and sisters that were extremely growth hormone deficient in comparison with those that were not. And remember, once you reach age 40 to 50, you're considered, your IGF-1 levels are just as low as young adults that are going to be considered to be deficient. So the benefit of this study is that there's a wealth of information showing the benefits of growth hormone replacement. And the dramatic findings of this study show that patients with either childhood or adult onset growth hormone deficiency, replacement is crucial. Why? For cardiovascular protection. This is another study, the Rancho Bernardo study, looking at IGF-1 levels. The relative risk of ischemic heart disease mortality was 38% higher for every 40 milligram per ml decrease in IGF-1 level. The lower your IGF-1, the greater your risk of cardiovascular disease and ischemic heart disease mortality. The higher your level of IGF-1, the greater the protection. Where would you like your levels to be? But you don't qualify based on the severe restricted guidelines. That's true. You don't qualify based on those guidelines, but that doesn't mean that you wouldn't benefit from taking growth hormone, because in every study, the higher your IGF-1 level, the less your risk of heart disease. The lower your IGF-1 level, the greater the prediction of cardiovascular disease and death. Where would you like your levels to be? That's my point. The higher the level, the more optimal, the greater the health benefit. We conclude that low baseline levels of IGF-1 increase the risk of ischemic heart disease and fatalities in men and women, independent of other risk factors. Where would you like your levels to be of all hormones? Optimal. But they don't qualify because their levels are, quote, normal. Yes, but they're not optimal. There's a big difference. Low IGF-1 identified in early and advanced atherosclerotic lesions, contributing to the process leading to plaque weakening, plaque rupture, and acute coronary events. In every study, IGF-1 is protective. It protects against plaque deposition. It protects against plaque rupture. Where would you like your level to be? High where it's protective, or low that increases your risk? It makes no sense to keep your levels low. But the restrictive guidelines are you don't qualify for replacement. Well, then this guy is going to die from ischemic heart disease. Well, that's not fair. Yeah, you're right. It's not. Who said it was fair? The increased risk of fatal ischemic events increase with low IGF-1. Low IGF-1 increases mortality. Another study showing, is there any study showing that you'll live longer on hormones and that you won't live as long when you don't replace? Yeah, this is a great study showing how protective it is, and you'll live longer. There is an anti-aging longevity benefit to replacement. These findings suggest that it's IGF-1 that's involved in the development and progression of fatal coronary arteriosclerotic disease in men and women. Measuring IGF-1 can be predictive of those people that are at risk. Well, almost all people over age 40, particularly over age 50, will have low IGF-1 levels. Another study looking at myocardial infarction in an elderly population. Our study shows that low IGF-1 activity increases MI and cardiovascular disease. Where would you like your levels to be? Levels with low circulating IGF-1 are at significantly greater risk of developing cardiovascular disease. We saw how it's protective. It reverses dyslipidemia. It reverses insulin resistance. It lowers visceral and subcutaneous fat and reverses all inflammatory markers. What a great drug it is for cardiovascular protection, and it's simply ignored. In fact, it's denigrated. You shouldn't use it because there's no anti-aging protective effects that are FDA approved. But that doesn't mean you can't use it. It doesn't mean you should not use it. The present study found inverse associations between IGF-1 and morbidity and mortality from all causes, both cardiovascular disease as well as cancer. It's pretty amazing interesting that we sort of ignore all the medical literature. It just makes no sense. I have somehow or another lost my screen. So I'm going to be slightly delayed in getting back on. Chris, can you fix my screen so I can get back on to the webinar?
Yeah, let me take a look at it. I'm seeing it okay. So
I'm not seeing it on my end.
you might need to reconnect to the meeting. Potentially, if you've lost connection, you could lose your screen.
Chris, I still see the screen also.
You can see the screen, Mary?
Yeah, I can.
Look on the bottom to see if he sees that.
Okay.
It might be he just.
Can you see the blue go-to meeting icon at the bottom, Neil, of your screen?
I'm back.
Okay.
I got it. Sorry.
Great.
Another study, these data suggest that IGF-1, IGF binding protein 3, has potential suppressive tumor effects in prostate cancer. We think that growth hormone causes cancers to grow. No. IGF binding protein 1, IGF binding protein 3 are apoptotic to cancer cells, breast cancer cells, prostate cancer cells. Where would you like your levels to be? I want my levels to be optimal. That's what is shown in the medical studies to protect against cancer. And again, IGF-1 and IGF binding protein 1 and 3 will predict ischemic heart disease mortality. It will also predict cancers. The higher your levels, the more protective against prostate cancer, which is the most common cancer in men. Where would you like your levels to be? Another study looking at cancer, we found a statistically significant decrease in prostate cancer risk across increasing growth hormone quintiles. We're still stuck on numbers. AACE is stuck on numbers. You don't qualify for it. But the studies show that the higher your level, the more protective it is. Yeah, but you don't qualify. You don't qualify for higher levels? No. But that's where all the protection is. Yeah. Then why shouldn't we all want to achieve optimal levels based on the studies to show the higher the level, the more protective it is, and the less disease and death? Well, because you don't qualify. We don't qualify for protection? No. That makes no sense. Now you see my sarcasm to Big Pharma, AACE, the FDA, and the AMA. They just don't get it because they just don't look at the studies. And when I show groups this, they look at me like, well, we didn't know those studies. Yeah, but they're there. The lower the level of growth hormone, the significant increased risk of prostate cancer. Where would you like your levels to be? We see the same thing with testosterone. The lower your testosterone level, the greater your risk of prostate cancer. The higher the level, the more protective it is. I won't go through the different mechanisms. The Endocrine Society recommends against offering testosterone therapy to all older men. Really? Yeah. Why? Because they don't qualify for it. Really? But what about the loss of the health benefit? That's tough. Is there a mortality increase when your level's low? Yes. Is there a mortality decrease when your level is high? Yes. Then why wouldn't you want your levels to be high? Because we don't recommend it. You don't recommend it based on what? Based on FDA restrictions. In every study to date, there's over 100 of them. I'll show you just one. Low testosterone levels were associated with increased mortality. In every study to date, the lower your level, the greater your increased mortality from heart disease and cancer. The higher your level, the more protective it is. Where would you like your levels to be? Remember the theme of this topic? It was mortality. This looked at 6-year mortality in men. Testosterone, IGF, and DHEA, all anabolic hormones, were evaluated. Age decrease in anabolic hormone levels is a strong independent predictor of mortality in men. What happens when you look at all three of them? All three of them combined, having multiple hormone deficiencies rather than just one, is a robust biomarker for health status in older people. I guarantee all older people, and by old I mean over 60, are going to have low levels. They're going to put them at risk. The higher the level, the more protection. The lower the level, the greater the risk. Where would you like your levels to be? And all three of them are predictive. Yet we ignore it. AAC says we don't recommend DHEA. We don't recommend testosterone to older men. And we definitely don't recommend growth hormone. But every study shows there's benefits to longevity when your levels are optimized. Well, we ignore those studies. Low levels, independent inverse association with atherosclerosis. When you want to build up plaque, keep your levels low. When you want to reverse plaque, then keep your levels high. What did that most recent study show in JAMA? Optimizing testosterone, it wasn't optimal, they raised it, increased soft plaque. But that was not hard plaque, and it was an outcome of MI or mortality. In every study, the lower the level, the greater the risk of plaque, the greater the risk of MI, and the greater the increase in morbidity and mortality and death. Yes, to the Chinese doctor, there are studies to show benefit. It doesn't make sense that we ignore them. Testosterone insufficiency, low levels, increased mortality over 20 years, independent of other risk factors. How many of these do we have to see? This is a sad one. Free testosterone concentrations were low in men that developed Alzheimer's disease. The higher the level, the greater the protection. Where would you like your level to be? It makes no sense that we say we don't recommend testosterone in older men. It protects against Alzheimer's disease. It reverses it. You can see it on SPECT scans. We don't recommend it. You don't recommend it because we don't. But that makes no sense scientifically. Yeah, you're right, it doesn't. JCEM, low levels associated with increase in all-cause, both cardiac and cancer. Study after study after study shows the same thing. Low levels predict worsening. High levels are protective. Where would you like your levels to be? High serum testosterone levels predicted a reduced 5-year risk, events in elderly men. Where would you like your levels to be? High. But AACE says we don't recommend it. The FDA says we don't recommend it. So you're recommending an increase in risk of death? That's what you're recommending? Yes. By not raising the level? Yes. That's what we're recommending. But that makes no sense whatsoever. You're right. This is from the Journal of the American College of Cardiology. What they say and what they recommend makes absolutely no sense based on the literature and the science. It's thoroughly amazing. Our findings of significant inverse association between testosterone levels and the risk of fatal and non-fatal cardiac events support and extend previous work showing an association between testosterone and cardiovascular mortality. Where would you like your levels to be? It's absolutely inexcusable that they say and recommend what they say, and it's purely based on politics and the desire to restrict. In the present study, testosterone levels in the highest quartile are associated with reduced cardiovascular risk in comparison with lower levels. Study after study after study shows the same thing, and the fact that we ignore it makes no sense. Here's the nice part about testosterone. We know that heart disease is an inflammatory disease process. How do you reduce the inflammation? You have to reduce visceral fat. You have to improve the body composition. With testosterone deficiency, there's an increase in visceral fat and insulin resistance and systemic inflammation. How do you reduce it? Testosterone. Yeah, but no one recommends it. Yeah, you're right. They don't recommend reducing the diffuse systemic inflammation that causes heart disease. They don't recommend that. Yeah, you're right. They don't. In every study to date so far, in patients receiving casodexamlupron for prostate cancer, it protected them against getting and dying from prostate cancer. Unfortunately, they all died from cardiovascular disease first. Those in the placebo group didn't die. Those that got casodexamlupron did die of heart disease. When you wipe out testosterone, it significantly increases systemic inflammation, which will increase plaque deposition and plaque rupture. And that's what AACE wants? Really? Yep. Now you see my criticism, now you see my passion, now you see my frustration, and it just makes no sense whatsoever. JCEM. Low testosterone levels increase risk of mortality compared with those that receive testosterone treatment. And the reason you don't want to give testosterone, the reason you don't want to recommend it, well, because they don't recommend it for use in older men. Yeah, but the mortality benefit is tremendous. Well, we ignore that. Really? You just want to watch them die, and you can protect, you give statins to help protect it. Why don't you want to give testosterone? Because we don't recommend it. Now you see the interesting controversy of hormone replacement. This is the great study that I was alluding to from JCEM. Testosterone has immune modulation properties, and if you use enough of it and you test these on your own, you'll see the importance of it. Testosterone suppresses the expression of the pro-inflammatory cytokines tumor necrosis factor alpha, interleukin 1b, interleukin 6, and increases the anti-inflammatory cytokine interleukin 10, and as well as C-reactive protein. If you measure tumor necrosis factor alpha, you can, and you measure C-reactive protein, you can. Before and after testosterone, you will see those numbers dramatically improve. Don't measure it in a month. Give it 6 months to a year when you reduce the visceral fat, and all these numbers will normalize. You cannot accomplish that with statins. Statins will increase the visceral fat and wipe out your testosterone, which will increase your inflammatory cytokines, the opposite of what we want to do, which is really a shame. In conclusion, testosterone replacement shifts the cytokine balance to a state of reduced inflammation and lowers total cholesterol. What a great drug it is. It's a shame that it's denigrated, and it's a shame that our peer societies don't recommend it and actually preach against it, purely for politics and economics. Inverse relationships were observed for deaths due to cardiovascular cause and cancer. So we all focus on testosterone and protection against cardiovascular disease and strokes. But what about cancer? There's a recent study that came out that showed that testosterone protects against 11 different types of cancer. It has apoptotic effects on cancer cells. It reduces visceral fat. It reduces the systemic inflammation that causes cancers to progress. So there's a multitude of different beneficial effects that have been reported in the literature, but overall you still have to look at outcome. Does giving testosterone help improve outcome and reduce morbidity and mortality from cancer? Yes, it does. To the Chinese doctor, yes, there are studies. Endogenous testosterone concentrations inversely associated with mortality due to cardiovascular disease and cancer. Study after study shows the same thing. Let's shift gears. Estrogen. We all know how bad estrogen is. Let me tell you a little story. I recently was contacted by a physician that took the course because this physician referred his mother to a doctor on the East Coast that had taken the WorldLink courses 1 through 4 and had a pretty good reputation for prescribing hormones. This doctor's mother was 72 years of age and went to see this doctor, lady doctor, for hormone replacement. And she was told by this lady doctor that she would not prescribe hormones to this 72-year-old lady because she was too old for hormones, and that the hormones could potentially cause harm. The doctor called me up and read me the riot act that this doctor practicing on the East Coast, and it's on the WorldLink sites, is giving this advice to patients that they don't recommend hormones because of potential risk. The male doctor was flabbergasted. I was too, absolutely appalled that a doctor could still be misled and mislead and think that somehow or another estradiol causes harm. And they're extrapolating the harm of estradiol to Premarin. They cannot do that, because all the studies show in all the early versus late studies that estradiol does not cause the estrogenicity and the plaque rupture in MI and stroke that Premarin does. But everyone still fears and thinks that it does, but it doesn't. And when this poor lady that's 72 is told, no, she doesn't get hormones, what's going to happen to her plaque? It's going to continue to build up because she's not on estrogen. What would happen to her plaque if she was on estradiol? It reverses it, and all the studies show that. What about testosterone? It reverses it. What about the visceral fat? It will lower it. So not treating this patient because of fear of this plaque rupture with Premarin has now led this lady to be concerned about taking hormones and fear it, where in reality she should have no fear of it and she should have been prescribed it, because they still just don't get it. I can't understand why relatively intelligent doctors don't get it. It's because they're reactionary and they are not analytical. If you're analytical, you'll be able to analyze these studies and figure out it's not harmful. If you're reactionary, you'll say, oh yeah, it is harmful, but WHI showed it was harm, so we shouldn't use it. And then it'll increase your risk of heart disease, strokes, Alzheimer's disease, urogenital atrophy, urinary infections, mood swings, osteoporosis, etc., by not taking estrogen. It just thoroughly boggles my mind to let people suffer and deteriorate because you are afraid of something that does not exist. It makes no sense. So let's look at estrogen. That's extremely confusing. We'll look at a lot more in section 3 and 4. Estrogen therapy-related risk occur at an absolute frequency of less than 1 per 1,000 women, or 10 per 10,000. And they're still considered to be rare risk. Well, what is that risk of estrogen therapy? The risk was blood clot. We'll look at those numbers to really see what that risk is. Again, this is estrogen, which is Premarin. The overall risk of DVT events is rare with estrogen therapy. That's Premarin. In the WHI trial, there were 8 events per 10,000 women in the whole entire cohort of women that took estrogen. However, if you whittle that down to women under age 60, the relative risk of blood clots was 4 per 10,000. 8 per 10,000 in the whole entire cohort was statistically significant by 1 patient, which is why they make claim to don't take oral estrogen, it causes blood clots. In 8 out of 10,000, and you say don't take oral because of 8 out of 10,000? Yeah, but it was statistically significant. So you're going to treat all of 10,000 women with a transdermal estrogen and avoid oral estrogen because of 8 per 10,000. Yes. All right, well, let's look at within 10 years of menopause or under age 60. That was 4 per 10,000. That was not statistically significant. So when you make claims that estrogen causes blood clots, it's in older women, not younger women, not within the 10-year window of menopause. And in fact, 4 per 10,000 was not statistically significant, and therefore it means that there is safety to using oral estrogen in the form of Premarin in younger women within the 10-year window of menopause. Please do not extrapolate that to estradiol, but everyone does. The DVT risk of Premarin are similar to those of other commonly used medications, such as phenabrate with diabetics. We commonly prescribe Tricor for lowering triglycerides. Well, the risk of blood clots with that is the same or even greater than that with Premarin. We don't bat an eye when we prescribe these drugs, and the risk is the same. But yet with estrogen, oh, you can't prescribe estrogen orally, it causes blood clots. Yeah, but what about Tricor? What about those drugs? Well, we don't worry about those. Well, you should, well, you don't. Now you see the reason that this article is written in Menopause Management. And what it does is it looks at and critiques and criticizes our assumptions of what we do and why we do what we do, which do not make sense based on numbers. However, in all the studies, in addition to the HERS and WHI, but all the other studies looking at statins and aspirin, either aspirins or cholesterol-lowering therapy with statins has been demonstrated to significantly reduce total mortality of coronary heart disease in women. In spite of the fact that there's a multitude of studies out there, we do not see any beneficial effect in reducing mortality with a statin or with aspirin. The cumulative data indicates that estrogen replacement therapy reduces coronary heart disease and total mortality in women under age 60. So, which drugs does everyone get? Aspirin and statins. Any decrease in mortality in any study? In primary disease studies? None. Well, then why does everyone use it? Because they're extrapolating the benefit with secondary studies to primary. You shouldn't do that. Which one don't they get? They don't get estrogen. Why? Because it's harmful. But all the data shows that it's estrogen that reduces coronary heart disease mortality, not aspirin or statins. But which one don't they get? They don't get estrogen. Yeah, but that's the one that's reducing the mortality. Why do we not get it? Why don't we not understand it? Why do we ignore the data in the studies? Everyone uses aspirin and statins. I can't believe the number of women that come to me that do not have heart disease that are on a statin and an aspirin, and they don't need to be. And yet they come to me and say, well, my doctor told me I can't take estrogen because it causes blood clots or something. And yet it's only the estrogen that reduces the cardiac mortality, and yet they don't get it. And yet everyone gets aspirin and statins, which has no effect in any study. It's thoroughly amazing why we do what we do is completely against the data. The cumulative data across 6 randomized trials and data on 11,000 women are not sufficiently large enough to demonstrate that lipid lowering with statins significantly reduces total mortality. Sorry, it doesn't. When you stretch the Jupiter study, most recently it showed for primary disease prevention, yes, there was slight improvement, but they don't know the true real numbers because they didn't release them. They just stated it in their study, but they still hide those figures from us. Why are they hiding it from us? Why don't they give us those numbers? They're afraid to. Why don't they? That's a whole other topic in itself. But nevertheless, in all these other studies, lipid lowering does not reduce mortality under primary disease circumstances. The WHI showed a null effect of aspirin on primary endpoint of non-fatal MI, stroke, and cardiovascular death. It didn't benefit, it didn't harm, but everyone gets it. Statins didn't benefit, didn't harm, but everyone gets it. Estrogen benefits them all. They don't get it. They don't receive it. Why? Because we fear it. The East Coast doctor is fearing giving estrogen because of this supposed increase in heart attacks and strokes with Premarin. Total mortality and cardiovascular death from any cause are unaffected by aspirin or statins. Estrogen has effects on calcium metabolism at the arterial wall, which accounts for its unique ability to reduce calcium content of atherosclerotic plaque. It decreases coronary artery calcification. It decreases intermediate thickness, plaque score, and calcium score. It reverses and shrinks calcified plaque and reduces calcium scores. Why don't you want to accomplish that? Well, because you're afraid of plaque rupture. That's not estradiol. Estradiol does not cause plaque rupture in any study. It causes reversal of the hard plaque that is so predictive of plaque rupture and heart attack. But yet you don't use it. You're afraid of it. Why is it? Well, because of the WHI trial. Don't extrapolate. Well, you have to assume. Don't assume. None of the NIH studies showed that estradiol orally caused any harm. Although ischemic stroke was reduced by 24% with aspirin, hemorrhagic stroke increased by 24% with aspirin. Well, that's good. But why do they all get aspirin? It makes no sense. Well, we got to give them something because we can't give them estrogen. Why don't you give them estrogen? Oh, because it's harmful. GI bleeding was increased by 22% with aspirin. I've had 2 people on aspirin die, bled out in the middle of the night, and they really didn't need aspirin. It made me it opened my eyes to the use of aspirin in people that don't need it. Overall randomized controlled trials show no overall reduction in cardiovascular events with aspirin. Yet, everyone gets it. With estrogen, there's a 32% significant reduction in coronary heart disease in women under age 60. What was the relative risk? The relative risk is 0.6. There's no reduction with statins or aspirin. There's a 32% reduction with estrogen. And the relative risk was 0.6. That's tremendous protection. Then why don't you use it? Well, because it causes plaque rupture and blood clots. It does not cause blood clots. Yes, it does in older women. That's 8 per 10,000. I don't use permanent in older women. Well, you have to extrapolate. No, you don't extrapolate the same in older women with estradiol. No study showed any increase in blood clots with estradiol. It's only Premarin due to the increased estrogenicity. Why don't you get that? Well, because they don't understand it. Why? Because they're not analytical. They're reactionary. Premarin significantly reduced several composite coronary heart disease outcomes by 34 to 45%, almost 50% reduction in heart disease outcomes. It's 0 with statins and aspirin. It's 50% with estrogen. They don't get aspirin. Nobody prescribes it because everyone fears it. Shame on them. The cumulative data indicated a 39% reduction in total mortality in women less than age 60 on estrogen. Yes, the Chinese doctor questions it. Here it is. There's a 40% reduction in total mortality in women on estrogen. Does it make you live longer? Yes. Does it reduce mortality? Yes. Then why doesn't everyone get it? Because doctors simply don't understand it. They're not analytical. They don't know the studies. They don't read. They're reactionary. Unlike lipid-lowering therapy, estrogen therapy reduces coronary artery calcium. And you can measure it, and you can watch it be reduced. And it is the most predictive factor in plaque rupture and plaque progression. And you can reverse it with oral estrogen and oral estradiol. But everyone refuses to use it because they don't understand it and they fear it, and what they use is a statin and aspirin, which is worthless. Estrogen therapy reduces atherosclerosis, cardiovascular disease, and total mortality in women under age 60. Aspirin and statins do not. All doctors prescribe aspirin and statins. They don't prescribe estrogen, which is what reduces mortality. What is it about it that you don't grasp or understand? They don't understand that they cannot and should not extrapolate the harm in older women with Premarin to younger women with estradiol. They don't get it. What about older women and estradiol? No studies. Later we'll look at this nice meta-analysis that was published in Naturitas. It was a meta-analysis of 7 studies in Europe of using estradiol. And in every study, it was a secondary study. These patients already had established heart disease. If estrogen is bad and causes plaque rupture, and you shouldn't use it in older women with heart disease, then in these studies, which there were 7, you should not use oral estradiol in women that have established heart disease. But they did, and guess what they found? 1, no increased risk of MI. 2, a decreased risk of MI and plaque rupture. 3, a decrease in calcification. Oral estradiol was protective in this meta-analysis of 7 studies. They were all secondary prevention studies in women with pre-established disease that took oral estradiol. They already had the heart disease, and they derived benefit. And yet people over here refuse to give estrogen to women without heart disease because they think that they may have heart disease and they may rupture it. They just don't comprehend it. The therapeutic effect of estrogen is not seen with any other intervention for coronary artery calcium, period. That which works the best is not being utilized because we don't understand it. Why don't we understand it? I guess they just don't go to the courses. Yeah, everyone should. The effect of statin therapy on breast cancer risk, you're not going to like this, ranges from 10 less cancers to 75 increased cancers per 10,000 women a year. What you didn't see before was this chart that shows that 1 or 2 studies showed protection with statins, 80% of the studies show there's an actual increase in risk and incidence of breast cancer with statins. So this was a cumulative looking at all of the different, here it is. There are some studies to show 10 less cancers, 8 less cancers, 2 less cancers. But in these studies up here, there was significant increased incidence of cancer with statins. Notice down here the West trial. The West trial used oral estradiol. There were 2 less cancers. Notice the WHI trial here. There's 8 less cancers with estrogen. There's significantly greater cancer risk with statins. Which hormones don't women get? Estrogen. Which drugs do all women get? Statins, which increase the risk. It makes no sense whatsoever. Unbelievable. 33% increased risk of breast cancer with statin use. Average 7 per year. Randomized controlled trials. In the WHI trial, breast cancer decreased with Premarin by 18%. All women think that estrogen causes cancer. The studies show, no, it decreases it. All people think, oh, well, statins are really good for you, and they get prescribed, whereas in reality, there's a multitude of studies to show an increased risk of cancer. Everyone fears estrogen. Everyone doesn't fear statins. Increased risk of breast cancer, decreased risk of breast cancer. They just don't comprehend it because they're not analytical. They don't know the literature. They don't know the studies. Resulted in 8 fewer cases of breast cancer per 10,000 women in the WHI trial. Which one would you like to be on? The one that increases the risk or decreases the risk? This is the West trial, and again with 17 beta estradiol, there were 2 less cases of cancer in the whole entire cohort. As we see with all the other estradiol studies in addition. Cumulative data indicates that in postmenopausal women less than 60, estrogen therapy significantly reduces total mortality and coronary heart disease. What is it that we don't understand about that statement? It reduces total mortality. Statins and aspirin don't. Estrogen does. Which one don't we use? Estrogen. Why? Because we fear it. Why? Because we don't understand it. It makes no sense. That's why this article was written, so that maybe we can understand. DVT risk with estrogen is rare, and the risk is no greater than other commonly used medications. The evidence of a preventive role of estrogen in certain postmenopausal women is stronger than ever, but yet we all fear it and don't understand it. And like the lady doctor on the East Coast, oh no, we don't want to give you estrogen. I was told that she said, well, the doctors are like Rousier on the West Coast. They're more progressive. They're more aggressive. But we're very conservative here on the East Coast. We don't do that because we don't want to cause harm. Really? By not giving this poor woman hormones and estrogen, you are causing so much more harm, and you don't realize it because you're not analytical. You're reactionary. Really too bad. The WHI confirms 40 years of consistent observational data showing that women who initiate estrogen therapy in close proximity to menopause within the 10-year window have a significant reduction in total mortality and cancer, as well as coronary heart disease. Read it and weep. Understand what that statement means and what it says. And understand that most doctors, including the cardiology world, will not understand this statement because they do not understand the studies, and they don't understand the implications of the studies. Estrogen therapy reduces breast cancer risk with efficacy similar to that of the selective estrogen receptor modulators, or SERMs. It's actually protective. Now there's a big push by the drug companies, which is unfortunate, to use the SERMs, to use Arimidex, anastrozole, to protect against breast cancer. And what you're doing is significantly increasing the risk of coronary artery disease, and you're increasing the morbidity and mortality associated with estrogen deprivation. They didn't read that last statement on the beneficial effects of protection. They completely ignore it. The reactionary and not analytical. Let's see what happens when you lose estrogen. Numerous reports, and they're all the same, link oophorectomy to higher rates of cardiovascular disease from loss of estrogen, osteoporosis, hip fractures, dementia, Alzheimer's disease. Memory impairment, that's great. Decline in sexual function, urogenital atrophy. Decreased positive psychological well-being, depression, mood swings, sleep disturbance. Adverse skin and body changes. Adverse ocular changes, macular degeneration, loss of central vision. Hot flashes and urogenital atrophy. That's what happens when you lose estrogen. And this doctor on the East Coast did not want to prescribe estrogen for the 72-year-old lady suffering from this. How can you deny the improvement with estrogen? How can you ignore the numerous effects showing what happens when you lose estrogen? It's thoroughly mind-boggling that they don't get it. Preservation of ovaries until 65 is associated with higher survival rates. What does that mean? That means even women that are menopausal that still have their ovaries will still derive some benefit from the estrogen that's produced by the ovaries, even though it's not much. It's better than removing the ovaries and completely wiping out any production of estradiol. The conclusion here is keep the ovaries in. There's a survival benefit to it, even though you're in menopause and it's not working. I wouldn't do that. If they need to be removed, remove them, and then replace it with estrogen. But it's interesting that even in menopausal women, maintaining the ovaries provides a survival benefit. Ovarian conservation until at least age 65 seems to benefit long-term survival. Why? Because ovaries produce hormones. Bilateral oophorectomy before age 45. Significant increase in cardiovascular mortality. Cardiac mortality. Estrogen replacement reduces this. And what they call NAMs recommend. Low dose, shortest period of time, and then stop it. And then what happens? Then you significantly increase your mortality. But that's not right, you're right. Well, yeah, but then you die. Yeah, you're right. But that doesn't make sense, you're right. Then why don't we grasp it? I don't know. I don't get it. I don't understand why we don't grasp it. I can grasp it. What I don't grasp is why others don't grasp it. Reduction in estrogen is associated with unfavorable changes in serum lipids. When you go through that menopausal transition, you get dyslipidemia. When you get dyslipidemia, you increase atherosclerosis in the carotids. When you increase plaque, you reduce blood flow, and you increase carotid artery intermediate thickness. How do you reverse carotid artery intermediate thickness? Oral estradiol. But everyone's afraid of prescribing oral estradiol. Yes, but that's what reduces it in the studies. Don't extrapolate the harm of Premarin to estradiol that we don't see in any of those studies. Nurses' Health Study, oophorectomy doubles the risk of MI. Oophorectomy before age 50 increases the risk of MI and heart disease. What is it that we don't understand about this and the replacement of it? Meta-analysis. Observational studies found more than double the risk of heart disease when you took out their ovaries. Every study shows the same thing. And when you're not treated with estrogen, then you die. Total cardiovascular mortality was significantly increased. That can be decreased and prevented with estrogen that women don't get. What do they get instead? Statins and aspirin. No statistically significant association with mortality was found in women treated with estrogen. Estrogen therapy alleviates the excess risk of heart disease, but many women don't receive this therapy. Why? Because their doctors don't understand. Why? Because they're scared. Why? Because they spoke with this East Coast doctor that said, no, you're too old for estrogen. Really? No, we're conservative out here. We just want to let you deteriorate and die. Really? That's what you want. It makes no sense. What is it that you did not get in these courses? Did you miss part 2? I don't understand. Shifting gears. If you're on estrogen but you want to lose the benefit of estrogen, what can you do? Estrogen replacement therapy is associated with improvement of cognitive deficits and reduced incidence of Alzheimer's disease. Read it and weep. Every study shows the same thing. When you want to increase your risk of Alzheimer's disease, do not take estrogen. When you want to increase your risk of Alzheimer's disease, go see this East Coast doctor that thinks women over 70 should not receive estrogen. I still can't get over that. It drives me nuts. Estrogen and progesterone alone in combination protect against glutamate toxicity of the brain. In contrast, when Provera was given, it failed to protect against glutamate toxicity. Progesterone has protective effects. It's synergistic with estrogen. Provera antagonizes all the beneficial effects of estrogen. It makes no sense to use Provera. Yet when you read the PDR, the adverse effects of progesterone are identical to that of Provera, which scares doctors away from using micronized progesterone, which is synergistic with estrogen, not antagonistic as is Provera. There's this BCL2 gene. It's good. This gene is good. When you upregulate it, it's protective. It is upregulated by estradiol. It's also upregulated by micronized progesterone. It is downregulated and blocked with Provera. It's unconscionable that any physician in the U.S. would still prescribe Provera to their patients. It's absolutely unconscionable with the amount of data and negative literature against it and the increased risk of breast cancer, the 5,000 successfully settled lawsuits against Wyeth for Provera causing breast cancer. It's just phenomenal. And yet we ignore that and still continue to prescribe Provera. Oh, we're just going to use a smaller dose. Oh, that means you're going to get a smaller breast cancer. Oh, that's good. It makes no sense whatsoever. I hope you enjoy and appreciate my passion based on the medical literature that shows what we should be doing, but what we're not doing. When you lose your hormones, increase in all-cause mortality, heart disease, strokes, cancer. Replace it with the right ones and reverse that. Estrogen also decreases risk of colon cancer. The most common cancer between both sexes is colon cancer. Estrogen can increase the risk of endometrial cancer. Oppose it with progesterone. Estrogen was shown to decrease all-cause mortality. That's both cardiac disease and cancer. One of the cancers it protects against is colon cancer. It's also consistent with several published studies suggesting a protective role of estrogen in the development of colorectal cancer. Every woman should be on estrogen unless there's a contraindication, and the only contraindication would be an active breast cancer. Progestins. This was published in OBGYN Management. The relative risk of invasive breast cancer was 1.0 with progesterone. In other words, no increased risk. The relative risk of breast cancer with other progestins increased significantly. Like by how much? Let's look at the chart. With micronized progesterone, the relative risk of cancer was 1.0. Perfect. The same as placebo. The relative risk with Provera was 1.5. Yikes. The relative risk with the new progestin, norethindrone, which is prescribed over Provera, the relative risk of breast cancer with norethindrone was 2.1. Great. Fantastic. Which would you like to be on, the relative risk of 1.0 or the one that increases your relative risk of breast cancer significantly? You want your wife to be on this stuff? You want your patients to be on this stuff? What does ACOG and NAM say? Well, the use of micronized progesterone could be an alternative. Could be? Well, you could still use the synthetic progestins, just use a smaller dose. Okay, great. Why? Well, you'd get a smaller cancer. Great. It makes no sense whatsoever what we do. If you want to protect against breast cancer and the morbidity and mortality from it, use progesterone, not a progestin. Studies report that progesterone is associated with a lower risk of breast cancer than the progestins, which significantly increase the risk. It makes no sense to use any progestin at all anymore. Don't forget the Cache County study. I will summarize it. Summary is, prior hormone use is associated with a reduced risk of Alzheimer's disease, but you have to use it for at least 10 years in order to derive any benefit. What does ACOG and NAMS now claim? Use the shortest dose, smallest dose for the shortest period of time and stop it. And when you stop it, what happens? You increase your risk of Alzheimer's disease. Well, that's great. Did they not read this study? I guess not. Yeah, but what about the harm? What harm? I don't see any harm in estradiol progesterone. Yeah, but with permanent Provera, I don't prescribe permanent Provera, and don't assume and extrapolate that they're the same. We miss the brain. Long-term estrogen therapy is associated with reduced all-cause mortality and confers this protection primarily through the reduction in cardiovascular disease, but there's also protection against cancer and Alzheimer's disease and diabetes. And the reason we don't want to give it is because we don't understand it. Vitamin D is a hormone and has a structure very similar to estrogen. Low vitamin D is independently associated with an increase in cardiovascular mortality. Where would you like your levels to be? As the Chinese doctor says, where's the studies that show that there's a benefit as far as longevity? Here's one. Vitamin D levels are independently associated with all-cause and cardiovascular mortality. The lower your level, the increase your mortality. The higher the level, the more protective. Where would you like your levels to be? Estrogen is important for cognitive maintenance. Estrogen is important for the neuronal network because of the protection against toxic damage. Estrogen is important because of protection against free radical-induced injury. Estrogen is important because it attenuates the toxicity of beta-amyloid protein. The most compelling evidence to date is that estrogen is neuroprotective, particularly in preventing and delaying Alzheimer's disease, because of the protection against the deposition of beta-amyloid proteins, which no drug does. Only hormones do. And yet we ignore those studies, and we ignore those hormones. The primary pathology is the deposition of this protein that kills the neurons. And you can protect against it with estrogen. You can protect against the cell death. What is it that we do not understand about all these data, studies, and research? Why is it that we ignore it? There's this enzyme called alpha-secretase. Alpha-secretase blocks the production of beta-amyloid protein. How do you increase alpha-secretase activity? You increase alpha-secretase activity with 17-beta-estradiol. It protects, it reverses. And the reason we don't want to use it is because, well, the lady doctor on the East Coast says she's conservative. Conservative how? She doesn't want to protect against Alzheimer's disease? I don't get it. I simply don't get it. Estrogen deprivation due to lack of ovarian function leads to beta-amyloid precipitation. And this can be reversed by estrogen administration that most doctors are afraid of or don't want to do because they don't understand. Reactionary, not analytical. Estrogen clearly has many important neuroprotective properties. One could reasonably postulate would be beneficial in Alzheimer's disease. What is it that we don't understand about this? Well, because we fear estrogen. Why do we fear it? Because we don't understand the literature. We don't understand the studies. We're reactionary, not analytical. Estrogen should be started at menopause and continued indefinitely. Okay, here's the most important paragraph of the morning. Estrogen as a possible preventing agent for Alzheimer's disease is an issue of overwhelming importance when the public health impact is considered. When I become Surgeon General, everyone will get estrogen free. Estrogen acts to enhance cell differentiation, increases neuronal growth. It's an anti-apoptotic hormone. You lose neurons with beta-amyloid protein. Estrogen is anti-apoptotic. It makes the neurons live longer. It has benefits in increasing the expression of ApoE. There's tremendous benefits to estrogen on the brain that we completely fail to understand, appreciate, and acknowledge. All prospective studies have shown an improvement of Alzheimer's disease with estrogen. Let me say it again. You missed it. All prospective studies, the patient has Alzheimer's disease. We're going to give them estradiol. I was told once the patient has Alzheimer's disease, you cannot give them estrogen. It makes it worse. No, you obviously don't know the prospective studies with Alzheimer's disease and estradiol. They clinically improve. Their SPECT scans improve, the beta-amyloid protein diminishes, and the clinical outcomes or symptomatic improvement is tremendous. What do we give? Naracept and Amenda. Worthless. What's the only thing that works? Estradiol. Which one don't they get? Estradiol. Why? Well, because we're conservative and we don't get it. It makes no sense whatsoever. Studies have shown a 70% estrogen-related reduction in Alzheimer's disease. And what is it that we do not understand about these studies? These findings have enormous public health implications, and the reason we ignore it is because we're conservative here on the East Coast. Really? You don't understand the health implications of estrogen deprivation and the protection of Alzheimer's disease that you can accomplish with it? No, we don't appreciate it because we're conservative. This is my letter to everyone on the East Coast that has to deal with conservative doctors. Move to the West Coast. We're not conservative. The window of opportunity is within the first 10 years of menopause. That's with Premarin. If you're going to avoid blood clots, then use it within the first 10 years. It's safe. But every study beyond the 10-year window with estradiol is also safe. Even in women that were 80 and 90 years of age that received estradiol for the first time. Even women in that meta-analysis that already had pre-established cardiac disease. They derived benefit. There was no plaque rupture. There was plaque decrease. There was a decrease in calcified plaque. There was a reduction in intermediate thickness. There was a reduction in MI in secondary studies with estradiol. What is it that you do not understand about that? We didn't know about the study. Nobody showed us. Come take the course. I'll show you the studies. And then you can become passionate like I am and not reactionary, but you can become analytical. Women that use hormone for a long period of time have lower rates of mortality and heart disease in comparison with women that don't. Which group would you like to be in? Well, back here on the East Coast, we're conservative. We let women die from estrogen deprivation. Really? You let them die from heart disease? Yes. Why? Well, because we fear it, because we don't understand the studies. I hope that now you understand the studies and the importance of understanding this. This is from the American Journal of Medicine. 19 randomized trials were evaluated. Bayesian, which is the most powerful way of doing a meta-analysis, showed a significant reduction in total mortality. There you are, Chinese doctor. Reduction in total mortality in postmenopausal women that take estrogen in comparison with women that receive no treatment. The most powerful meta-analysis shows protection. And the reason you don't want to use it is because we're conservative on the East Coast. It makes no sense that you ignore the data and the studies. DHEA, low DHEA also predicts death from all causes, cardiovascular disease, cancer. Another study, 27-year study showing that the lower your DHEA, it's a greater predictor of longevity. The higher your DHEA, the lower your blood pressure, blood sugar, diabetes, and heart disease. I remember this endocrinologist saying, we never prescribe DHEA. It's not good for anything. Really? I guess you don't read the literature. Well, the literature shows that it's of extreme benefit. Then, well, what is it about it that you ignore it? It makes no sense to ignore the studies. DHEA and protection against cardiovascular disease. DHEA levels are inversely related to death from cardiovascular disease. Where would you like your level to be? The higher, the more protective, the lower the increased risk of disease. I guess the endocrine world ignores this. This is from the New England Journal of Medicine. Why do you ignore it? Why did they do the study and why do you ignore it? Okay, coming down the home stretch, thyroid. Decreasing levels of free T3 are associated with poor outcomes on virtually all domains of function. Yeah, but this is a mortality lecture. Okay, let's get to that. Low levels of free T3 are associated with an accelerated increase of disability, declining global cognitive function. Translated, doctor, I'm losing my memory. Well, that's too bad. Isn't there something you can give me? No. What about optimizing thyroid? No, that doesn't work. Really? Well, my friend's on thyroid, and she says she's much better. Decreasing levels of free T3 are associated with increased mortality. The American Thyroid Association says free T3 is a worthless test. It doesn't predict anything. Really? JAMA says the lower your T3, the greater your risk of mortality. This is a mortality lecture. Where would you like your levels to be? Well, why did you prescribe thyroid if the TSH was normal? Because their T3 was low. Well, why does your T3 need to be high? Well, if you want to live longer, it should be. That's why we use it. It makes no sense to ignore the literature. In our study, we found significant association between low level of T3 and increased mortality. I want my level to be optimal. It is. Me and mine, our free T3s are 5 and 6. We feel better, we function better, our cholesterol's low, our visceral fat is down. The endocrine societies say, if your TSH is normal, you don't need T3. They completely do not grasp it and understand it. Lastly, this is the last one. Recent studies suggest that relatively low thyroid function within the clinical reference range is associated with increased risk of heart disease. Yeah, but the level was normal. Why did you give it to them? Because the level was in the low normal. Well, why does it need to be high normal? Look at the study and see what it shows. In this study, if your TSH is low, your hazard risk for cardiac disease was much less. When your TSH was 1.6 to 2.4, there was a significant increased risk of coronary heart disease. And when your TSH was in the highest reference range, 2.5 to 3.5, which is still perfectly normal, there was a significant increased risk of cardiac disease and death. Where would you like your TSH to be? I want mine to be around 1.0 or less. If you maintain it in the normal range from 1 to 2 and 2 to 3, you significantly increase your risk of mortality from cardiovascular disease. That's why we do what we do. Results indicate that relatively low but clinically normal thyroid function increases the risk of fatal heart disease. It increases mortality. Yeah, but your levels are normal. I know, they're not optimal. There's a difference between normal in the reference range and optimal. The TSH should be low. The free T3 should be high. Well, this was a nice long lecture. It took a long time. I'm sorry that it took so long, but nevertheless, I wanted everyone to see and appreciate the importance of optimizing thyroid for cardiovascular disease protection in elderly women, as well as all the other hormones that also do the same. Okay, I hope that was fun. I know it was long and intensive. I hope that you're able to split this up. I'm finished with section 1 and 2, and I will entertain any questions. Chris, Dana, are there any questions?
Neil, can I just interrupt real quickly? If anyone joined us a little bit later, if you want to leave a question for Dr. Rosier, if you look in the lower right-hand corner of your screen, you should see a chat box where you can enter your questions to Dr. Rosier. Back over to you, Neil.
I'm pooped. I'm tired. It's a bluebird day outside. Temperature is around 25 degrees. Sunshine, blue skies. I wish everyone a great day. Thank you so much. See you at part 2. Bye-bye.
Thank you, Dr. Rosier. We look forward to seeing everyone at part 2. Have a wonderful rest of your day. Thank you.